There is always light if you're brave enough to see it, if you're only brave enough to be it. Good morning, all. It's my pleasure to be present here virtually and to welcome you all on behalf of Pushpagiri College of Dental Sciences to the 5th Annual OOO Conference of the year 2023. OOO is a conjoint facilitation of ASMIC, Association of Stomatologists and Imagiologists of Kerala, KSOMP, Kerala Society of Oral and Maxillofacial Pathologists, and AOMSI, Association of Oral and Maxillofacial Surgeons of India. Let's commence the session with prayer. Now I invite Dr. Ethan Thomas, Professor and Head of the Department of Oral and Maxillofacial Surgery, Honorable President of OOO Kerala Chapter, for the welcome speech.
A very good morning to one and all. We have all gathered here for the inaugural session of the 5th OOO Conclave. The Kerala State Chapter, which started this conference about 5 years back in 2018, has been so successful and very continuously doing this program over the past 5 years. I'm very happy to say that the registrations and the response for this conference are overwhelming. We have more than 550 registrations for this conference. We also have a very good number of scientific paper presentations, more than 250 paper presentations from different specialties of oral and maxillofacial surgery, oral and maxillofacial pathology, and oral and maxillofacial radiology from the delegates, undergraduates, and postgraduate students. And we also have eminent faculties who's taken their time and effort, who's going to enlighten us over the coming 2 days with interesting topics, lectures covering 2 topics from each specialty. I'm sure it's going to be a great learning experience for one and all. I would like to welcome all the senior respected members, the senior respected persons of all the specialties, our patrons, the patrons and the senior members from oral and maxillofacial pathology, from the specialty of oral and maxillofacial radiology, and oral and maxillofacial surgery. I also would like to welcome all the faculty members who are being with us for the coming 2 days to enlighten us on various topics. I also would like to welcome the panelists or the judge persons who's been actually having a very tough time in assessing the papers, or various scientific papers in excess of 250 papers. I also would like to welcome all the participants from the undergraduates, postgraduates, and even the faculty members who have registered from different parts of the country and made this conference successful. I hope this 2 days is going to be a very interesting and very learning curve and learning section for you, and I'm sure it's going to benefit one and all. Thank you.
I invite Reverend Father Ebi Bhadakantara, Director of the Institution Pushpagiri College of Dental Sciences, for the directorial address.
Good morning to one and all present here. I am extremely happy to be a part of 5th OOO Conference organized by the OOO team, Pushpagiri Dental College. It is great to know that the conference has been providing excellent platform for the specialists and dental surgeons to showcase their deliberations. I'm happy to know that there are more than 250 paper presentations and the sessions are taken by internationally reputed speakers. I wish the organizing team and conference all the success and hope the participants will enjoy the scientific fest. Wish you all a blessed day. Thank you.
Now I invite Dr. Eddie Matthew, Principal of Pushpagiri College of Dental Sciences, Professor and HOD of Department Prosthodontics and Bridging Plants, for the principal address.
Happy to know that Pushpagiri College of Dental Science is organizing the 5th OOO Conclave, which is being collectively organized by the 3 specialty departments of Oral and Maxillofacial Surgery, Oral Medicine and Radiology, and Oral Pathology departments. It started in 2018 with the interest taken by the Pushpagiri College of Dental Science. And since its inception, it has grown to a level where today we have more than 500 participants from the different specialties, like from the faculty members, from the practitioners, the UG students, and the post-graduation students. And also we have about 6 keynote speakers who will be giving you very much informative talk about the recent advances in your specialties. I wish this conference will be a scientific feast for all the participants who will be attending today.
Now I invite Dr. Babu Matthew, patron of the OOO Conclave.
Friends, I am indeed very happy to address the 5th OOO Conclave at the Pushpagiri College of Dental Sciences, Tiruvalla, where the Kerala unit of OOO was initiated. The conclave gives great opportunity to the teaching faculty, to the undergraduates and postgraduates for presenting their work as papers or posters. In addition, there are 6 stalwarts giving keynote lectures on aptly chosen topics. We are now passing through an era where there are fundamental changes in the approach towards diagnosis and treatment. Robotic surgery is being introduced to the management of head and neck cancers. To arrive at a final diagnosis, histochemistry and molecular techniques are becoming the routine. The study of saliva and liquid biopsy is becoming more and more popular. The area of imaging, the application of 3-dimensional printing and the assistance from artificial intelligence has resulted in opening up the window to have a closer and detailed, clearer look at the soft and hard tissues. I hope to hear more and more about these advances in the coming days of the conclave. I congratulate Dr. S. Sunil and Dr. Epen Thomas and their team for organizing this webinar. I wish all success to the 5th OOO Conclave. Thank you.
Now I invite Dr. Veena Verma, President of Association of Stomatologists and Imagiologists of Kerala.
Invited guests, respected faculty members, organizers, and my dear students. A very good morning to one and all. I consider it my proud privilege to address this august gathering and be part of this conference. It has been 5 years since this program started. The purpose behind this conference is to integrate and enhance knowledge which is segregated in watertight compartments. These kinds of interdisciplinary programs help knowledge dissipation, which ultimately aim at benefiting the patient. The old and outdated are questioned and analyzed. with proper sifting and sieving. Acceptable ones are reinforced and unacceptable are redefined, repaired, rebuilt, or discarded. And innovative and current are accepted, assimilated, and amalgamated. The hard work and dedication of the team behind this program is praiseworthy. And Dr. Sunil deserves a special mention for his tremendous effort. This happens to be a litmus test for the faculty, both veterans and amateurs, and an academic bonanza for the PG students. I wish the program all success. Thank you.
It's my great pleasure to welcome Dr. Sunil S., Vice Principal and HOD of Department of Oral and Maxillofacial Pathology, President of KSOMP, and Honorable Secretary of OOO for felicitation.
Greetings to you. I am much delighted to address you on the occasion of the 5th OOO Kerala Conclave. OOO was established on 6th May 2018. Since then, it has provided an excellent platform to share the expertises, to share the researchers, to share the ideas and cases by pioneers, experts, postgraduates, undergraduates, and practitioners. OOO Kerala is a conjoined collaboration of the Association of Stomatologists and Imagiologists of Kerala, Kairali Society of Oral and Maxillofacial Pathologists, and Association of Oral and Maxillofacial Surgeons of Kerala. This year, being in the online platform, the 5th OOO Conclave have received an immense support and collaboration from the registrants from different states of India. And indeed, we have more than 500 registrations so far and about more than 250 scientific presentations submitted. The organizing team of 5th OOO Conclave have arranged about 6 internationally reputed speakers, which include the international speakers, national speakers, and the state-level speakers. I'm sure that these 2 days will be a fruitful scientific extravaganza. Thank you.
I invite Dr. Deepa Ennis, Honorable Secretary of Association of Stomatologists and Imagiologists of Kerala.
Warm greetings to one and all. It's quite gratifying to know that the Pushpagiri College of Dental Sciences is hosting the 5th annual OOO Conclave in association with ASMIC, KSOMP, and AOMSIK. As you all know, the OOO Conclave is the right platform to bring the 3 dental specialties under one roof. Organizing such an event at this point of time reinforces our objective of developing an environment for sharing of knowledge between these 3 dental specialties. There are quality papers that will be presented in the conference, and we are sure that this occasion will provide an affable environment for the keynote speakers, faculties, postgraduates, and undergraduates to exchange their views and ideas with others. With immense pleasure, as the Secretary of ASMIC and Treasurer of OOO Kerala Chapter, I convey my warm greetings and felicitations to the organizing committee and the participants, and also extend my best wishes for the success of this conference. Thank you all.
I invite Dr. I. Varghese, Patron of OOO Conclave.
Dear friends, the 5th OOO Conclave is being held on 9th and 10th March 2023 under the auspices of the Pushpagiri Dental College, Trivandrum. OOO means oral surgery, oral pathology, and oral medicine. The interdepartmental discussions and interdepartmental meetings are essential today for the students as well as the practicing dentists. I hope and wish that the deliberations of the conference be useful to the student population at large and the practitioners in general for their betterment of dental practice as well as acquiring knowledge in the field of oral pathology, oral medicine, and oral surgery. My best wishes and prayers for the success of the conference. Thank you.
Now I invite Dr. Ram Manohar, patron of OOO Conclave.
I'm very happy to note that the OOO Kerala chapter is holding the 5th OOO Conclave on the Zoom platform on 9th and 10th of this month. I have no doubt that the conclave will be a great platform for coordinating the clinical, pathological, and surgical management of oral diseases. I wish the program all success. Thank you.
With extreme delight, I welcome Dr. Sharon Sarababu, Organizing Secretary of 5th Annual OOO Conclave, for delivering the vote of thanks.
On behalf of the organizing team of the Pushperi College of Dental Sciences, being the organizing secretary of the 5th OOO Conclave, first of all, my sincere thanks to God Almighty for making this a reality. Thanks to OOO Association, office bearers and the members of the speciality of AOMSI Kerala chapter, ASMIC, and KSOMP for giving an opportunity for the Pushperi College of Dental Sciences to host the Kerala State 5th OOO Conclave. Special gratitude off to the management and administrative heads of Pushperi College of Dental Sciences, headed by our patron, His Grace Most Reverend Dr. Thomas Markurilos, the Metropolitan Archbishop of Tiruvalla, our Chief Executive Officer, Reverend Father Jose Kallumalikal, our Director Institutions, Reverend Father A.B. Vadakandala, our Principal, Dr. A.B. Mathuti, our Vice Principal Academic, Dr. S. Sunil, and our Vice Principal Administration, Dr. Benny. I would like to express my sincere acknowledgement to the keynote speakers, moderators, and the judges of the scientific presentation for their valuable contribution to the conclave. My thanks and appreciation to all the heads of the departments of various colleges all over India, the faculty delegates, the postgraduate delegates, and the undergraduate delegates for being part of the conclave. My sincere acknowledgement to the Department of Information Technology, Pushperi College of Dental Sciences, and NACFAST. And a conference cannot happen overnight. The wheels start moving a week ago. It requires planning and a bird's eye for detail. We have been fortunate to be supported by a team of very active and dedicated faculties of the Department of Oral and Maxillofacial Surgery, Oral Medicine and Radiology, and Oral and Maxillofacial Pathology of the Pushperi College of Dental Sciences. I also would like to thank the Master of the Ceremony and the students of the organizing team who worked overnight for the grand success of the OOO Conclave. Thank you. Thank you all.
Now, let us all raise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Here comes the end of the inaugural session. To acquire knowledge, one must study, but to acquire wisdom, one must observe. A quote by Marlin Barnes. On this delightful occasion, I'm welcoming you all once again to OOO Conclave 2020. Let's embark this journey of conversation with enthusiasm and privilege of filling in us capacity by introducing the first speaker of the day, Dr. Reggie Matthew, Associate Professor of Maxillofacial Radiology, University of Leeds, on the topic interpretation and application in dentistry. Welcome, sir. Now I would welcome Professor Dr. E. and Professor Dr. Captain Vivek, moderators for the session. Dr. Ethan Thomas, Professor at HOD Department of Oral and Maxillofacial, Consultant Surgeon at Pushpagiri Medical College, City. He is also the Honorable President of the Kerala Chapter and has over 45 national and international publications. Dr. Captain Professor Vivek V is a professor and head of the Department of Oral and Maxillofacial Dental College, Thiruvananthapuram. Now, I would like to ask Vivek to introduce the first speaker of the day.
Well, thank you. Thank you, Dr. Mika, for that words of introduction. And we are right on time, and we would like to start the session as scheduled. And we are all here for the much awaited scientific deliberations from eminent faculties. So to start off with today's session, may I call upon my colleague, Dr. Vivek, to introduce the first speaker of today's session, Dr. Reggie. Over to you, Vivek.
Good morning to you all. Let me, I hope I am audible. I hope I am audible.
Yeah, you're clear, audible.
Okay, fine. Good morning to you all. Let me introduce Dr. Reggie Matthew. And I have got a huge list of accomplishments, and I would not take a lot of time saying the whole, reading out the whole thing about Dr. Reggie. I would just summarize and say it in one sentence that he is a highly accomplished person, especially in the field of oral medicine and radiology. And I would like to hear from him a lot of things regarding the CBCT, which he is going to present today. And I would not like to take a lot of time reading through his CV, which goes on to around 3 to 4 pages. So I would like to hear Reggie Matthew. I would just make a simple statement saying that he is a very accomplished person and he is an expert in his own field. We would like to listen from you, Dr. Reggie, please.
Thank you so much. Thank you.
Welcome. Yeah, welcome, Dr.
Thank you,
Reggie.
Dr. Ipan.
It's been great to have you out here. And like what Dr. Vivek is telling, we are in fact the OOO Kerala 6 chapter, and this particular conclave is very proud and privileged to have a person like you, such a caliber in terms of academic achievements and clinicals, publications and whatnot. And I'm sure the postgraduate students will be actually lucky to have words of wisdom from you. And over to you, Dr. Reggie, for your presentation.
Thank you so much. I appreciate. Can you all hear me?
Yeah, very well.
I'm just going to start my presentation. If you can see my screen, is it okay?
Yes. Just put on the slideshow, please. That's all.
Okay.
Yeah. That's perfect.
Perfect. Okay. Well, good morning, everyone. I see there is a lot of participants. That's amazing. You know, it's almost close to 150 or 160 as when I counted last. And Dr. Sunil was telling me there's more than 500 participants who have registered. This is a big project. I mean, I'm happy that I could be a presenter here and share some of my knowledge, which I gained throughout the years. I will be talking about CBCT interpretation and application in dentistry. But before that, let me thank the organizing committee. Let me thank the Pushpagiri Dental School and all the faculties, all the staffs, and all the students who took this project. This is a big project. I mean, it's just how you all put this together is mind blowing, and I wanted to congratulate each and every one of you. I want to take my time to congratulate Dr. Sunil, Dr. Anuna, and Dr. Sherlin, who has been in constant touch with me, talking about how what I should present, and all the things which they supported towards this moment to make this work. I think you can all hear me. No, it's like I just don't want it to be. Is the internet okay? I mean, can you all hear me clearly?
You're very
Perfect.
loud and clear. You're very loud and clear, doctor. Please
Perfect.
proceed.
Perfect. Thank you so much. Just a brief introduction. I was born in Kerala, so I am a Malayali. So I am born in Kerala. I was born in here in Kerala, and I moved to US 16, 17 years ago. 17 years ago, I finished my BDS, my dental school from Vinayaga Mission. So any of my friends who are attending from Vinayaga Missions, I just wanted to shout a big hi. And I came to United States, took my boards and everything, went to University of Connecticut, UConn, to do my oral and maxillofacial radiology residency. UConn was a great opportunity. This is one of the best time in my life when I got the acceptance in UConn, because UConn is specifically different when you talk about radiology. It has the medical school and the dental school in the same campus. So I was well versed with MRI, ultrasound, and other things which radiology brings into page. After UConn, I got my job in Midwestern University. It's a great school. It was a new school when I joined. It has grown so fast, and we have almost close to 140 students. This is where I joined. Like this is the science hall. This is just one part of the university. It's a 100 years old university. This is a new building. We have two dental schools, one in Arizona and one in Chicago. I'm the oral maxillofacial radiologist in Chicago. This is our clinic. We have almost close to 280 students in probably every day in this building. It's a great school. I see if my dean might be attending. So if he is attending and if he's hearing me, I just want to say hi, and a great guy. I just want to play a small video. I don't know if this will clearly show, but I will stop in between if it's not playing well. Just wanted to show a small video about Midwestern University where I work, and
I think the video is not playing.
Oh, it's not playing?
It's not playing.
Oh. Can you see the?
Your screen is visible, but the video is not.
That's okay. Don't worry about it. It's on the website. Let me show you the pre-clinic here. And we do have CAD CAM, and we do our students place implants. They plan with CBCT. They have a training to do CBCT planning, and they do place implants. Each students are required to place at least 2 implants, but most of them place at least 4 to 5 implants, and some of them even more, even 10 to 15 implants. This is our CBCT unit. We have 3 CBCTs. Again, this is a dental school, so it's not a postdoctoral program. We have three CBCTs. We have an ICAT Flex. This is our newest edition. We had a classic ICAT Classic. We replaced with an ICAT Flex. This is the Akitomo and the Plan Maker, which is basically takes the panoramic image or the OPG, and this one has a CEF and PAN and a CBCT also. This is the radiology viewing room. Our students sit here and plan CBCT is plan implant planning. If I have some time, I think I wanted to show an implant planning also, and that's the clinic. I just wanted to not want to waste time, so I want to get directly into my topic today. Today I'll be discussing about the basic principles of CBCT and its applications. We'll try to see how we can systematically evaluate any image. Now I'm very keen on this systematic, the word systematic. Every image, even if it's a panoramic image, if it's a full mouth radiograph, or if it is a CBCT, all images has to be evaluated in a systematic order, because here it's very important that you don't miss any lesions. We might be taking a CBCT for an implant planning, but we are responsible for the entire scan. So if there is any pathology in that scan, by rule we are liable for those lesions. So we would be, how we learn, how we teach our students is basically to look at systematically. Don't look at the pathology which is right in front of your eyes. For an example, you probably might be taking a CBCT to evaluate a third molar extraction. Do not go and straight away look at that third molar extraction. And even if it's in a panoramic image, don't go and look at the third molar first. Evaluate in a systematic order, and then finally, last thing is to go and look the region of interest or why you took a. So this is, I'll go systematic. I'll show you a little bit briefly how we could evaluate a CBCT scan systematically. And again, I would be showing you some of the cases, and if I have time, I wanted to share one implant planning. And this is my slide where I wanted to actually talk about any image. That's what I briefly said. Any image, when we take a scan, whether it's a panoramic image, full mouth radiograph, I as a radiologist, I am not looking for a pathology. I am not hunting for a pathology. When I look at an image, what I look is normal anatomy, because you, me, everyone has the anatomy is the same. So what I do is, as I scroll through the image, I am looking at the normal anatomy. And if there is a variation in that normal, or there is a change in that normal anatomy, I stop and look at the variation and see see if it's a variation of normal or if it's a pathology. I'll show you an example. Let me put this one just so that. So this is an inferior alveolar canal. It's a cropped CBCT image. You see this as a very normal image. No, so that is what we look at. We see it. But this is a bifid canal, which you can see, which would be a variation of normal, which probably should have a concern when you are placing an implant. But it's not a pathology. It's a variation of normal. But when you look at this one, this is this is actually a pathology. No, like you can see that how the widening of that inferior alveolar canal. You can see that this is the canal has been widened, and it's most likely a schwannoma or a tumor inside the inferior alveolar canal. Now, what do you do with this? You have to send it for an MRI. Here we are required to send an image. If you find something, you are required to send it for an MRI, especially to a physician, and from there you probably get to look at an MRI. An MRI is great because it kind of shows you a soft tissue areas. Now the CBCT, it's great to see bone, but it does not have a contrast resolution, or it does not show much of the soft tissue. So when you look at it, when you take an MRI, you have different sequences. Different MRI uses radio frequencies or RF pulses. So there are different sequences which you would be able to look. Some of those sequences are like T1 imaging. You probably might have heard about T1 imaging, where the fat might appear bright, and T2 imaging, where the fat and the the water is bright. And there are other sequences called stir sequences and flare sequences and all, which in a stir sequence where only the water is bright, and whereas in the flare sequences, the water is suppressed. I don't want to go in details into that, but what I wanted to tell you here is that anytime when you see a change in normal anatomy, we wanted to look at it and see if it's a variation of normal or if it's a pathology. And if it's a pathology, it's an important thing to refer that patient outside so that adequate care can be given. Now, this is a great article. I would encourage you to all to read this article. This is an article which shows how a first year student or a second year student or probably even a first year resident would try to come up with a diagnosis. And this applies for everything. This applies for for a panoramic radiograph or an OPG. This applies for a CBCT images, and this applies for everything. This is a step-by-step analytical approach we do. We call it as a forward reasoning. There is a forward reasoning what we do. We look at, rather than jumping and finding out what this lesion is and giving a name for that lesion and putting a multiple differential diagnosis, what we do is we will look at a lesion and see the extent of the lesion. We will see what that lesion is doing to the structures around it. How does that periphery looks? How is that? Do you see that scalloping pattern? How do you see that resorptive pattern? You can see the displacement of the premolars. We can always see the thinning of that inferior cortex. I cannot see the inferior alveolar canal. I'm kind of positive that the inferior alveolar canal might be pushed downward. So we look at an image. So when a student comes to me, or when a student brings this radiograph, my question to him is, can you describe this lesion? If they can describe this lesion, it's a most likely that they would come to a diagnosis, a much better diagnosis. And with CBCTs, those days of putting 10 or 15 differential or 6 or 7 differential diagnoses, those days are over. Because with a CBCT, you would clearly see those buccal and lingual expansions. You will see the cortex perforations. You would be able to narrow it down to very, 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 maybe 2 or maybe, in fact, 2 or maybe even 3 differential diagnoses. Not more than that. Because we could see a benign pattern, we could see a malignant pattern, we could see all those changes in the bone much more clearly 3-dimensionally. So that's one. And there is another approach. We call it as a backward reasoning. Again, this article describes everything about that. Now, if you look at this, everybody knows that this is an idiopathic osteosclerosis. This is a dense bone island. So you look at it. Sometimes people look at an image, they really know what it is, So should I want to look at those periphery and to rule out? What the article says is that once you have a backward reasoning or a non-analytical approach, you still would want to rule out some things. In this case, you wanted to rule out if it's a periapical cementoosseous dysplasia, or if it is any other pathology, so that you can have those diagnoses. Now, my goal with all these slides was for any students who are in first year or second year, or probably a third year, final year, describe your lesions. Look at those lesions. Think why would I call it as an idiopathic osteosclerosis? Why can't I call it as an periapical cementoosseous dysplasia? And what is the difference radiographically, imaging wise? What is the difference between those kind of lesions? You wanted to also look at what other lesions could appear like radiopaque like that. So things like that. Try to ask those questions in your mind: why, when, how, age of the patient. Age of the patient is extremely important for some of those lesions. So that is what I wanted to actually show you. This is a case. Look at this panoramic image, or an OPG as we call it. Even if I have taken this to evaluate those third molar, I wouldn't jump right into that third molar area and look at the third molar first. I would go systematically. I would start with my right condyle. I would go all the way down, and you could see some things happening here, which I would show you in CVC, with a CVCT. But I would follow those ramus, and I will follow this inferior cortex. I would go to the opposite side. I will look at that condyle. I'll look at the glenoid fossas. I'll see those pteriomaxillary fissures, those posterior wall of the maxillary sinus, the inferior wall of the maxillary sinus, the zygomatic process of maxilla, the infraorbital rim. Again, the hard palate, the nasal septum. I'll evaluate each and everything, all through the maxilla, all the ways, all the things. Look at first prior to even looking at those anatomy, I probably would look and see, is the technique right? Is the patient positioned right? All those things are extremely important to make those diagnoses. It's not like what you look for an image, it's the things behind an image which actually brings you to that excellent radiographic diagnosis. So once I've looked at everything, you can see that I can't see that external oblique ridge here. You get the external oblique ridge is gone. So the next thing, what you have to do is to ask for a CBCT. Now, whenever I am in doubt, it's when I wanted to have an additional information, we would refer for a CBCT. And as you can see, you would see those. This is an osteosarcoma of the mandible. Of the mandible, you could see those clearly, those changes that have occurred. And again, this is my graduated class. This is almost like 2-3 years ago. I think it's 2 years ago when COVID was, and what we give is we give a radiology T-shirts. So any student who has done more than 5 CBCT planning with CBCT implant planning, they get a T-shirt. So this is my students who have graduated, and they're doing amazing now. Now let me begin into the principles of Con-beam CT. Am I rushing fast? Is it audible? Am I going a little faster? I have a lot of slides that I'm taking a little.
You are very audible and you are moving at the right pace, doctor.
Okay, thank you, sir. I appreciate. Thank you so much. So when you look at a CBCT, and you all know that it's a 3-dimensional image. Now, panoramic image was really came into the picture in 1960, almost 1970, 1980. It became very popular, and then it has been used very widely now. You know, we all know a panoramic image. It's almost like we can't get out of panoramic image. We all usually take OPGs for any number of reasons, but 2-dimensional imaging has its limitations. Now this is a great example which I show my students. It's almost like a stack of cards. 2-dimensional imaging. There is some degree of magnification. Of course, structures are superimposed on each other. If you look at here, yeah, I could see that and the B is kind of fading. But when I go into a structure C, I can barely see anything. So those structures are superimposed each other. There is a degree of magnification, some degree of distortion, especially when you consider how you are placing the patient. But when you come to the CBCT, even though it's a slices of images, I could take each one of those slices, rotate those slices, and see that slice 3-dimensionally. So this is a great slide just to show that how this one is different. Now, there is a lot of machines in the machines. When I started radiology almost 12 years ago in Yukon, there was not much of CBCT machines. Now I went to the midwinter meeting a couple of weeks ago, and it was, I mean, the technology has been changing. Like I heard from some of you, like the 3D printing and the artificial intelligence. We have something called now 3D printed brackets. Now orthodontic 3D printed brackets are there. Now the aligner industry is exploding. So there are a lot of changes happening in dentistry. Most of the dental side is moving very fast into digital dentistry. So digital dentistry is catching up phase, and I think probably in 1 or 2. I mean, it's already there. Probably in 1 or 2 years. I mean, it would be mostly all digital dentistry rather than the what me and probably some of our older generation might have learned. Now, what is a CBCT? CBCT has an X-ray source and a detector. Earlier, we had a different kind of detectors. Now we are called intensifying screens. Now we have the flat panel detectors. Now the X-ray source is connected with the flat panel detector by a gantry, and as the X-ray source rotates around the patient, multiple sequential images are created. I would call it as a LAT-CEF and AP-CEF images. Again, the good part of this CBCT is that it's not continuous radiation. As that rotates around the patient, it is not, the radiation exposure is not continuous. It's given as pulsed radiations, so that the radiation exposure is less on the patient. So you could see that this is actually Aquarian, and since we acquire the whole field of view, just one rotation is enough to get the images required for reconstruction. So this is what happens when you look at it. You basically so multiple sequential images are created, almost close to 150 to 500 images are created. All this single images are called raw images or basis images. They're combined together to form a projection data. This is sent back to a computer which uses a FELSCAP algorithm to create the images what we see. And that is a very short description about I think that about how a CBCT is acquired, and I could go into details, but as a clinician, I think that's probably enough to understand what a CBCT is. Now, there are a couple of things which I would mention, and most of our radiologists, most of the people who are using the CBCT are very aware about this field of view, voxel size, and scan time. Now, what is a field of view? Field of view is the anatomical area where you acquire the image. So a smaller field of view is mostly for an endodontic purposes. 8x8, I kind of take this 8x8 during the implant, and if you wanted to see a lesion, I would go with 11x10 and 17. Those are the field of view. Voxel sizes are also important. The smaller the voxel size, you get a better spatial resolution. Now, CBCT does not have a good contrast resolution when you compare with CT. What is a contrast resolution? Contrast resolution is the shades of gray. That means when I move from the skin, when I move into the muscle, when I move into the fat tissues, I would see those shades of gray clearly. I could clearly describe or clearly see that structures more clearly. Whereas spatial resolution is if two objects of different density is placed close to each other. Let's say that a root and a PDL space, if they are placed close to each other, how clearly you can differentiate between them. That is spatial resolution, and CBCT is great with spatial resolution, and that helps us for endodontic purposes. So if you have missed canal, if you have a root fracture, if you have a small radiolucency at the root apex, some accessory canals in the root, all this is great because with a great spatial resolution and with a low voxel size and low field of view, you could clearly see those structures very clearly. So that's a great thing. And the voxel size, I mean, voxel is a three-dimensional representation of a pixel. So when you talk about voxel, it's an isotropic voxel, whereas CT has anisotropic voxels. When I say isotropic voxels, which means that the length, the width, and the depth is same, which is excellent. So that what you measure is you get a very, very reasonable, very, very accurate measurement. Now I'm going to skip this slide, and I'm going to show you a field of what is how can a voxel size and a field of view be a different field. When you have a smaller field of view and you have a smaller voxel size, you could see that lesion very clearly, whereas this one you would barely see it. So how clearly you can see this one, if again this inferior alveolar canal, those trabecular patterns and everything, that's really, really good. Now I have to also talk about the field of view. Now, if you take a small field of view, and if you see a pathology, or if you see any lesion, of course, this is probably an idiopathic osteosclerosis, so it's not a big deal. But if you see a pathology, and if you only get half of that part of that lesion, you are supposed, by rule or by the standard of care, which has been released by American Academy of Oral Maxillofacial Radiology, you are liable for that lesion. So you will have to go in and take a larger field of view. You'll have to get a larger view. You cannot ignore any lesions. Of course, if it's normal anatomy, of course not. But if you get part of a pathology, let's say that you took a maxillary sinus and you see the complete obliteration of the maxillary sinus in a small field of view. You are supposed to take a larger field of view and evaluate if there is if the maxillary sinus ostium is intact, or if there is a drainage of maxillary sinus ostium. So keep in mind, when you see a pathology, you are liable as here, and I think the rules in India is also changing. So here it's a big issue, so that we cannot ignore a lesion and think that, okay, fine, that's fine, I didn't get it, so I don't have to diagnose it. So we are supposed to go back and review it. I have the axial view, which is the anterior posterior view. And like any image, we are looking at patient's left side here, and the right side. We have the coronal view, which is superior, inferior, right and left, and also the sagittal view, which you have. Axial views are horizontal cuts. Horizontal, I would compare it like if you take a loaf of bread and slice it, each and every slice you can take it out, depending upon, and the software allows you to create the thickness of that slice. So if you want 1.5 millimeter thickness, you could cut those slices as 1.5 millimeter. If you want 2 millimeters thickness, you could cut that into 2 millimeter slices. Now, before even I go into looking at any of those any images, one thing which I really wanted to look into how you wanted to evaluate an image. Sometimes if the patient is slightly rotated when you are taking a scan, the first thing is to reorient the data. Like you can reorient the data, you can make the data look straight, reorient that data so that the midline is clear. That's the first step to do. Let me see if I can open a let me see if I can open a CBCT. Now, can you see my CBCT here?
Not yet. I can see your main screen only, the title slide.
Okay, let me move that to that. How about this one now? Can you see it now?
No, it's still the same. I can see your title slide.
We can see that taskbar too. That's all.
Okay. Oh, this is a great image I had. I wanted to show you, go through that anatomy a little bit before I and I have a case which I wanted to show you about airway.
Looks like you have still selected the title slide only as per what we see from your screen.
You were not able to scroll through the images, and you didn't see my.
The last one, what you wanted to show us, that particular image, we are not. I can see there was
actually that image had come. We could see the image, but it was not like progressing beyond that.
Okay, can you see this CBCT image? Can you?
Yes.
I'm scrolling through the image. Can you see it?
We can see that scroll. We can
You
see
can
the scroll.
Okay, we can see the scrolling.
Right.
Okay. So you can see the CBCT image, which I am scrolling now.
What we are seeing is that how we are interpreting the what is the principle of CBCT, the X-ray beam and
what we can see is actually a schematic representation of the image, or image formation rather.
So
we can see a diagrammatic
slide. You are on the 21st slide.
Okay, let me share my new screen then. Oh my God, you should. If you don't see my images, please, can you see now?
Yeah. Yes.
That is good. Right.
Perfect. So did you see my? Perfect. I'm so sorry. Stop me if you didn't see it, so I can show what I am presenting. Did you see my older slides? Everything when I was talking?
Yeah.
Okay, perfect.
Everything is perfect. Just this particular part, what you are asking.
Oh, awesome. Thank you so much. Thank you so much. Now I am opening a CBCT just to show how I am evaluating that CBCT, how I systematically evaluate those CBCT. Now this is this software is called an in vivo software. We just recently updated our in vivo software to in vivo 6. There are different softwares in the market, and you probably will know about. There is Romaxis from Planmaker, On Demand, tons of software. When I heard that Pushpagiri is using Sirona. That is great, you know. So you have all kinds of different softwares. Our school uses this software called In Vivo Dental, which is a Californian company, which kind of really introduced this CBCT software very early on, and they didn't make much of a changes. They didn't update much of a changes. It was very well made. So I'm going to scroll through the image and see how I evaluate a CBCT. Now you can see this axial image. No, this is the axial image. This is the sagittal image, and this is the coronal image. Now, I start with an axial image. You can bring it up like this. I can start with an axial image, or I can start with an axial image. The way I start is I start craniocaudally. I'll start with the top, go all the way to the bottom, and if you are very new to the CBCT, and if you are just probably trying to learn, some of the students, if you are new to the CBCT, I would encourage you to keep a pen and a paper next to you. You wanted to scroll through each. Now the goal is to learn the anatomy. Like I said, you have to know the anatomy to make a diagnosis. So you look at an image, you find the anatomy, and then if there is a change in the anatomy, you stop there and look to see if the change is variation of normal or if it's a pathology. Now, I never open a image to find out a pathology. I open an image to look the anatomy. So this is the frontal sinus. You can see the frontal sinus right there, and you can see the frontal crest right here. And as I'm going to scroll a little bit down, you can see this small dot right there. That's the crista galli, and I can bring that right there and see those crista galli right there. The lateral wall of the orbit. You could see that orbit appearing, and as I scroll down, you can see the greater wing of sphenoid right here. The greater wing of sphenoid. I'm scrolling down. You can see the ethmoidal air cells, the anterior, middle, and the posterior ethmoidal air cells. You can see the sphenoid sinus right here, right here. And as I scroll, you could see the superior orbital fissure. That's the superior orbital fissure right there. And this one is the optic canal. And you might know this one, this is the dorsum cellae, and this is the pituitary fossa. Now keep in mind, this pituitary fossa is important because any tumor, any adenoma of the pituitary can enlarge this fossa, can cause destruction of these walls. So when you look at the pituitary fossa, you wanted to see the size of the pituitary fossa. As I mentioned earlier, the contrast resolution is not great with CBCT, but if there is an adenoma, there probably might see some degree of destruction of these walls, and of course a larger enlargement of the pituitary fossa. But what is the normal size? Normal size, if it's 10 millimeter, 11 millimeter, I would call it as a normal size. So I can scroll down. Again, as I scroll, I could see that we are entering into the middle cranial fossa. And right here, what you see is the infratemporal fossa. This is the inferior orbital fissure, which you could see there. And I'm scrolling down. You could clearly see the carotid canal right here. The carotid canal right here, and I'm scrolling the squamous part of the petrous and squamous part of the temporal bone, and I'm scrolling right here. You could see the foramen rotundum, right here. So this is a very important area right here. This is pterygopalatine fossa. No, it's always good to look at structures where things can go wrong. So you probably would be able to give anything and everything can go wrong. So in a human body, but there are some areas which probably you wanted to keep get a second look, or probably you wanted to see a second time, especially when you are starting to evaluate. So this is pterygopalatine fossa. You can see that how that pterygopalatine fossa communicates with the infratemporal fossa. This is the infratemporal fossa to the pterygomaxillary fissure. So that's the pterygomaxillary fissure, how that communicates with the infratemporal fossa. If you go straight right here, you can see the spinopalatine foramen where the pterygopalatine fossa connects with the nasal cavity through the spinopalatine foramen. Now, why am I mentioning all this? This is because any perineural tumors in these fossas would be able to spread into different areas, and it's a nightmare for a surgeon if you see a perineural tumor. I still remember my radiology board exam. When I sat there to take the diplomate, there was one case which I have to take 14 cases. You have a set number of time to diagnose, write the report for 14 cases. But one of those cases was this perineural tumor spread from the pterygopalatine fossa. And again, with a CBCT, it will be amazed that you probably wouldn't even see anything. It would just be slightly widened. So you might want to look at those areas very clearly. And as you scroll down, you can see that pterygopalatine fossa is opening into the middle cranial fossa through the foramen rotundum right here. That's the foramen rotundum, which so I talked about infratemporal fossa. I kind of talked about nasal cavity, and I'm introducing into another fossa, which is foramen rotunda. This is all connected together. So any perineural tumor which goes into this fossa will spread easily into all. And we all know this greater palatine foramen, no? Greater palatine foramen right here, which opens into the maxillary area. So it's also have connection to the oral cavity. This is the pterygopalatine fossa right there, which you could see it on the axial image right here. And this is the spinopalatine. This is the greater palatine foramen. And it also connects into the orbit through infraorbital fissure. So all these connections it's extremely important. So when you look at those structures, when you scroll through those anatomy, you wanted to keep an eye on those areas. You wanted to see if those areas are widened, if those areas are enlarged. You scroll through this right now. What is happening here is the I'm sorry, I'm looking for the time. This is this carotid canal, which you can see clearly the carotid canal. And again, this is the Vedian canal, which you can see, and there's a lot more of anatomy, which because of the time limit, I'm just going to scroll through it. The condyle, see how that axial views, and again, one more thing before I go into the next slide. What you wanted to see is this nasopharynx right here. This is the torus tubularis. This is the opening to the eustachian tube. This is the pharyngeal recess, or the fossa of Rosenmuller. If you could clearly see, let me enlarge this one. This is the fossa of Rosenmuller. So this is the pharyngeal recess. 50% of the nasopharyngeal carcinomas occur in this area. So you wanted to look at those areas very clearly, so that you are not. And again, you can see the mastoidal cells and other things. Now, this is the internal auditory canal. If you look at here, this is the ear ossicles, the malleus and incus. If you look clearly, it looks like an ice cream cone. The ice cream right here is the malleus, and the cone is the incus. So it looks like more of an ice cream cone. This is the internal auditory canal. Now let's look at the sagittal view. I'm going to scroll through it fast. This is the clivus, very important area. You wanted to look at this area, extremely important area. Numerous amounts of lesions can occur in this, where you can see those anterior, middle, and again, nasopharynx here, the inferior turbinates. You can look at the soft palate, look at the hard palate, the tongue, and everything. Now, because of the time limit, let me jump into how I plan for a obstructive sleep apnea. Like again, CVCT is not, and you can see all these images right here. Well, these are all the volumetric images. Not the best image to diagnose, but it's a great image to actually talk to the patient and explain it to the patient where you are going to place an implant or how those structures looks and everything. Now again, we have the implant, but since I'm showing you an implant planning, I am going to skip this implant planning here. Which here also you could use those implants. You can place an implant. Just gonna show you right like that. And again, you would be able to. I'm just gonna show you. Okay, I know that this is not the area, but just all these functionalities are there. Now the airway analysis. Now, when you look at those airway, you will have to understand that you will have to look at the nasal fossa. You will have to look at the paranasal sinuses. You will have to look at the nasopharynx. You will have to look at the oropharynx. This is the nasopharynx. This is the soft palate. We start the oropharynx and then the hypopharynx. Tongue position is important. So again, it's very controversial to see if we could diagnose obstructive sleep apnea with a CVCT. I wouldn't say like that. I would say that we can actually evaluate if the patient is predisposed or if the patient has any chances of having that obstructive sleep apnea. That is what CBCT is used, because any position, like the tongue position, sometimes you have a bite block where the patient will be biting, or if the patient is raising the tongue to the roof of the mouth. All this changes the airway space. So any dimensional changes and this is very static image, whereas airway is more dynamic. The patient is lying down, again, can you evaluate? Yes, you would be able to evaluate those maxillary sinuses, those nasal cavities, but probably you still need that polysomnography, which is actually the sleep study, to evaluate for it. That's the gold standard to evaluate for sleep apnea. Now what is an apnea? Apnea is actually a reduction in the airflow of more than 90%, and hypopnea is the reduction of airflow of more than 30%. So we have something called AH. A stands for apnea, H stands for hypopnea. We have something called an AH index. That index is what determines if the patient is, and again, if you have at least 5 to 15 events per hour, we call it as mild. If you have more than 15 to 30, we call it as moderate. And if you have more than 30 events, we call it as a severe sleep apnea. But let's do some measurements. And this is getting very, very popular in US, but the airway analysis and a lot of people are doing it. So I'm going to create a point right here. Let me take off this lines. I can take off these lines right here, and I can click on those points and actually go in and try to see if I could measure those airway. And again, this is a very rough measurement, so don't hold me to it. So you can see that the minimum area is 270 millimeters square. So this patient is okay. This is if it's I would call as a mild case or a low risk case if this measurement would be somewhere around 100 to 150. But if this measurement, and again, you can scroll down to see the axial images and clearly evaluate also. You could scroll down with the axial image. If this measurement is less than 50, that is a severe case. That is a high risk patient. We call it as a high risk patient. If it is 50 to 100, we call it as a moderate risk patients. And if it's above 150, low risk, and this is 270. So those are the things which we could evaluate. Now, we all know
Doctor,
that. Yes.
I'm sorry to interrupt. You have another 15 minutes to conclude. 15 minutes, my doctor. 15 minutes. Yeah. Thank you. I think that will be enough. I'll be yes. So I will. Is that Pramida there? That's right. Hey, Pramida. Yeah. Hi. Nice to see you.
Very happy to see you. I'm very much excited.
Okay. Thank you so much. You are. Well, I'm going into that implant case next. So those are the things which we look for sleep apnea. And here we have oral appliances, and what it really does is that it kind of opens up, just moves that mandible slightly forward and downward, creating a little more space for the breathing. But CBCT is there. A lot of people use to evaluate the studies. The research is happening. A lot of data is there right now. So at some point, you would see it's so much of changes that's going to happen. Dental MRI is already there, but it's not in the market. The research has been done, and dental MRI is already been, but it's not in a massive production. Of course, massive production always happen when there is a need for selling. Why Conbeam CT became so famous is not because of the diagnostic. From personally, it's mostly because of the implant, and the implant industry was becoming so big, so that kind of guided the CBCT to explode really quick and really fast. Let me come out of this, and again, there is, due to time limit, I'm not going to show you everything here, but I just wanted to briefly mention the airway analysis and talk about a little bit of sleep disorders and everything. Let me see where I can find my slides, and I go have. Okay, let me go through the implant surgical guide planning. Now we plan surgical guide in-house. We have all the equipments to do it. Sometimes it's a lot more of a work to really implement that. Our Arizona campus prints and students are taught to do a surgical guide planning, print out their own surgical guide, take it for the surgery, which they use to place those implants. Now that is important, because when the students goes out, they could easily implement that in their practice as far as US market is concerned. So we do teach that quite a bit to our students. Now, this is, as you know, it's written everywhere. It's a plan maker, Romaxis software, great software for an implant planning, and also surgical guide. Now, PlanMaker recently came out with a 3D printer called Creo. It's a 3D printer. They were waiting for an FDA approval. They just got an FDA approval, so it's in the market. So the good thing about PlanMaker is you have a intraoral scanner, which is PlanScan. You have the software, Romaxis is their software. You have the CBCT machine with PlanMaker, and of course you have the 3D printer. So everything integrates together with this. So any surgical guide planning, you have to have a CBCT image and also an intraoral scan. So I have a CBCT image here, which I could open. I'm trying to open. Let me see if that's the CBCT. Now, once you have the CBCT imaged open, I can bring in that intraoral scan. I can take an intraoral scan of the patient with a PlanScan, iTero, any of the intraoral scanner which we have, and then browse that area where that file is stored. If you're taking it with the PlanScan, you are basically in the same Romaxis software. So you bring in that intraoral scan, you bring in that 3D volumetric image. Now, what you do now is you want it to superimpose. So you're selecting points, exact points where in the intraoral scan and also in the 3D volumetric image, so that you can merge this file together or superimpose this file together. So we get a soft tissue definition also. So once we select those points, those points has to be a slightly far apart. So once we have that you're basically joining it to, and again, I'm going to, because of the time, we're going to use that automatic match, which will match automatically. And again, this would give us a outline of how that intraoral scan has matched with the CBCT scan. And you can scroll through that coronal image to basically see if it has matched properly. And I'm looking at those scans and seeing if it has matched clearly. Once it has matched clearly, now I can bring in also a crown which has been planned. So the software recognized that yes, the intraoral scan was done. So it uses the existing match, and a crown is been planned, and it's rightly gone into this exact area. Once I have that, I can go into something called an implant library, and I have those library. Under the implant library, I have all kinds of implants. You could look at those implants, and I'm going to start with a Strawman implant and select the Strawman implant, which I need. I have a surgical kit. I'm going to use that surgical kit. Well, Strawman also has the sleeve, which we get from the Strawman. So we add that implant to the area where you want it to place. You basically place that implant, and you can look at that centric occlusion. You can basically look at the plan and see how that implant can be placed on axial, sagittal, and coronal images. You can see those axial images right here, and this yellow is the safe zone. So I'm going to prosthetically driven. I'm going to put that implant in the right area, looking at the crown, matching up things together, so that once I have everything together. Now, once I have it, I can just bring the sleeve and look at the sleeve and see if it's touching those gingiva. I can actually move the sleeve slightly down, depending upon how you want it to move. You can actually bring it closer, and again, you could do change those apparently to which area you want. And you can also look at what is the total drill length. You can see that the total drill length is 20 millimeters in this case. And once you have selected that, you would be able to just bring in a guide design. Now I'm going a little quick here, but guide design is actually 6-step, which is actually given in this side right here. All the 6 steps is guide design. See how easy this is. When you do couple of things, like when you do 5, 6, 7 of this implant surgical guide planning, it becomes so easy that you could easily drive this and actually print it. So I just wanted to show you how this could manually. So now I can look at this red areas, right? What you see is undercuts, which I could easily remove, and I can set that manually and kind of adjust it in a way so that it looks, the sleeve looks good. Now I can draw the guide area. Now if I left click, I would be able to draw a guide. So keep in mind, this is a anterior implant, so it's very good. So because we have multiple teeth here, but if you're going into the posterior area, you might want to add some bars, which I will talk about later. Now you can also right click and also remove those additional areas. So I can right click. I am removing those things. Left click is add. Right click, remove. So that's what we are doing. Once I see that guide is okay, I still could change the guide width and everything. But once I'm fairly okay with it, now the next thing is to just see that guide. Just see the guide alone. Now, if you look at here, that is the thickness of the sleeve. I mean, thickness of the materials, and you could use those wall thickness. This wall thickness is basically what it represents is the thickness around the sleeve. So this is the wall thickness which is around the sleeve, which means that you probably wanted to have a little more thickness around the sleeve when you compare with the adjacent sides. So I have 2.7. I can change it to 3 if I want. I've changed that to the 3, and then once I have that, I can. And this gap to teeth and gap to sleeve, that's the printer which you use. Here we use Creo printer, so this is automatically always in this format. And then I can remove sharp and thin edges. I would highly recommend to use this so that you can remove the sharp and thin edges, and then you come back. You could always add, and this is the guide. Preview guide. Now I can preview the guide, and I can just preview the guide alone. So that's the guide which we created.
Dr. Ananda, 3 minutes more to go.
Sure. Thank you so much. I appreciate it. Thank you. And then I'm drawing that guide. I'm making some areas where you could put some windows. Of course, you wanted to keep, and you can put a bar in regards to areas where you wanted to put. If it's in the molar, I would add. If it's this tooth missing, I would add a bar here. And if this tooth is missing, I would add a bar for much more support. And then you can name it. You can place the patient's name. You can do what the name is, and then you can actually view it exactly where you wanted to see, and then create then send this STL file to a printer for fabrication, and that you will be able to do it. I wanted to show a lot more of stuff, but I have to be careful about the time, so I am right now. Maybe I think I will stop right here. Let me see if I could bring my presentation. This one more quick slide before I stop. This is the VDN canal which you see, those perineural tumor spread in the VDN canal, and these are basically intracranial meningiomas. A lot more of slides, but I'll take some questions. This is a case of carotid artery calcifications. I'm gonna want yeah, I could speak forever. I'm sorry. So I'm gonna stop here. And then, is there any questions you wanted to talk? And if you wanted to ask some questions, I would answer.
We had posted in the chat box that if there's any queries pertaining to any of the matters that just been discussed, the faculty is very happy to take up. And no queries so far. Probably you've been very descriptive enough to make them understand the basics, whatever has been required for the subject. That's an excellent review, I believe. No queries.
Okay, probably. I mean, there's two things. If you don't have questions, then it probably might be a little more complicated. Or is it? So next time when I come to Pushpagiri, I wanted to come and see you all and give my regards, and thank you for inviting me.
Yeah.
If there is any question, Dr. Sunil and Dr. Sherlin and Dr. Anuna, everybody has my email, so you could send me some questions. I think Dr. Pramida also has my email. You probably would be able to get my email. If there is anything in regards to research or anything we could work together, I would be very happy to work with any of your students or any of your faculty to come up with something.
There's one single query or question, I would say. It's an interesting one in the chat box. What do you think is the number one pathology that non-radiologists miss most frequently from these type of investigation? That's a very tricky question to ask.
Very tricky question. But I would say one thing. For a panoramic image, and I'm saying panoramic image deliberately because that's the most common image, more than CBCTs which are taken. In a panoramic image, most people miss like osteoporosis. You could look at a panoramic image and you could evaluate the generalized reduced bone density. You could look at those trabecular pattern. You could look at that inferior alveolar canal, which is almost kind of washed out because of the generalized. And you could maybe think that, yeah, there is this problem. This patient might be osteoporotic, and maybe have that sent to a physician to evaluate for osteoporosis. And what happens, unfortunately, is that when a patient might be osteoporosis or have osteoporosis, patient falls down, breaks the bone, and finally says that, oh my God, I'm having osteoporosis. And all this time we have dental radiographs, which could probably, if you look at the right things where you wanted to look, you probably might be able to. And the second one is carotid artery calcification, which you see it at the C3, C4 level. You probably might be that CBCT. Anything and everything you probably will be able to miss. Maxillary sinus is important. You don't want it to miss anything in the maxillary. You want to see that maxillary sinus ostia clearly. If it is near complete obliteration of the maxillary sinus, I would refer to an ENT. But that's okay. I hope I kind of touched it.
Yeah. Thank you, Dr. Reggie. Over to Vivek. You want to place some concluding remarks, Dr. Vivek? Well, if not, let me just say a few words about this extensive lecture, what you have prepared. Really appreciate the efforts that you have put in to prepare this slide right from the basics and all depth and details. And I'm sure it has been very much beneficial for those participants who have actually logged in, specifically at 8:30 or 9 a.m. Because 160 is a very good number for a students' conference and overall delegates conference to have. And I'm sure they have all benefited, and really appreciate and really thank you for that time and efforts and excellent presentation, sir. Thank you so much for being with us and sharing your valuable time.
Thank you so much. Thanks for your invitation and have a great day. Enjoy the rest of the day. Let me
Thank you,
get
sir.
some sleep. Thank you so much. Take care.
Thank you,
Bye-bye.
sir. Thank you. Bye, bye, bye.
For this enlightening sessions. I would also like to thank Professor Dr. Ethan Thomas and Dr. Captain Vivek Wee. Thank you. I'll be pressing the token of appreciation. First, I invite our speaker, Dr. Reggie Matthew, sir, to accept the token of appreciation. Now I invite Dr. Captain Vivek Wee to accept the token of appreciation. Professor Dr. Ethan Thomas, sir, to accept the token of appreciation. Here we come to the end of the first session. Our speaker for the session 2, Professor Dr. Shankar Gowda Patel, Professor, College of Dental Medicine, Roseman University of Health Sciences, South Jordan, Utah, USA, to speak on the topic, Navigating the Academic Publishing Landscape. Welcome, sir. Now I would like to welcome Professor Dr. Baby John, sir, and Dr. Professor Jayanti P, our moderators for the session. Dr. Baby John, Dean Vinayaga Mission, Shankaracharya Dental College, Salem, Tamil Nadu, President of Tamil Nadu State Indian Dental Association, a fellow of Pari-Fortune Academy, and has over 45 national and international publications. Welcome to the session, sir.
Thank you.
Dr. Jayanti P, Professor, Department of Oral and Maxillofacial Pathology, Assisia College of Dental Sciences, Kollam. She's a recognized PhD guide of Kerala University of Health Science and is a fellow of Indian Association of Oral and Maxillofacial Pathologists. She has published over more than 40 articles in reputed national and international journals. She was assistant editor of GIDA and associate editor of GOMFB. Welcome to the session, ma'am. Now I'd like to request Dr. Baby John, sir, to introduce the speaker, Professor Dr. Shankar Gowda, sir, to the session.
Thank you, Dr. Mega. Hope I'm audible, right? All right. At this outset, let me congratulate the organizing team for having taken this initiative through online, the 5th OOO Conclave. After having said that, the speakers whom you have selected, I believe and I'm sure the audience, the participants, all the postgraduates will be highly benefited. Let me take the pleasure of introducing our second keynote address speaker, Professor Dr. Shankar Gowda Patel. Professor Dr. Shankar Gowda Patel has his credentials as Masters in Dental Surgery and Oral and Maxillofacial Pathology. He's also got a doctorate degree, as well as he's got his FRCP, MDS, and so on. To say his credentials, it takes quite a long time. I'm summing it up with a brief note, and a person who is a very good academician as well as a researcher. So to say a few words of his expertise, he is a faculty and researcher who has got immense interest in immunobiology, oral pathology, oral oncology, molecular biology, and molecular oncology, and some more. Dr. Shankar Gowda Patel received his PhD in medical biotechnology from the University of Siena, Italy. His thesis subject was on the effect of water pipe smoking, tobacco, on oral keratinocytes. His formative research training and experience at Hong Kong University has prepared him to be an ethical and effective researcher. He is an associate professor at Jisan University from 2016 to 2022. He's also in School of Dental Medicine, Siena, Italy, and he's a distinguished visiting professor at the Center of Molecular Medicine and Diagnostic, also in our Savitha University in India. Having said that, he has got a lot of publications for his credentials with more than 7,000 citations. He is into various editorial board, and he's also placed in the top 2% of the scientists in the world across all disciplines. So we have a person here today morning who has got a vast experience in the subject of oral pathology or research. And he has got awards as a best peer review award by Publons and Web of Science in 2019, awarded for highest number of impact factor papers in Jazan University in 2021. So he's a notable researcher, publications and presentations in University of Illinois, Chicago, cancer stem cells, as well as in University of Illinois, Introduction to Dental Research, and many more laurels for him. So I'm really happy to say a few words in his CV achievements. So over to you, sir. I'm very, very happy to introduce you. Thank you so much.
Okay, good morning, everyone. I hope I'm audible. I hope
Yes,
everyone
sir.
can hear me.
Yes, sir, you're audible.
Yes, audible.
Yeah. So today the topic of my research is navigating the academic publishing landscape. So here I will try to share, I have experience of more than a decade now into research and publications. And this is not only my passion, obsession, it is an addiction also for me regarding publications. So I will share my experiences today of what you need to, how you should start your research and what minute details you should see while submitting the article or while publishing your manuscripts. So my experience I'm going to share with you today. So, okay. So, I work in College of Dental Medicine, Roseman University of Health Sciences, and I'm also the part of Global Burden of Disease Collaborative Network from University of Washington. And at present, I have around 9,000 citation as of today. With an H index of 36. So my editorial positions, these are my editorial positions, so I'll not waste much of time here. And I'm the reviewer for many journals because every alternate day I review manuscripts for the top scientific journals available. So Albert Einstein once said that education is not the learning of facts, but the training of the mind to think. So we need to think a lot as far as research and publication is concerned, and novelty is very, very important as long as research and publication is concerned. So what any country to grow, the government and industry has to fund in research and innovation. So research and innovation driven countries are progressing a lot. And the countries which invest money into research and innovation, there is growth, and because of that growth, the government and industry can again fund. So it is a cycle which we need to understand. So initially you need to invest, and then what patents you get and what products you develop, again the government itself will be benefited. So if you want to be a global leader, you have to invest in research and innovation. So next is for sustainable future and economic growth, right? So you need to innovate, and countries which spend most on innovation and research these are the 5 countries according to their GDP, gross domestic product. These are the 5 countries which invest more in research and innovation, and they are the future leaders. So what is research? Basically, it's a way of innovative thinking, and it is to see what everybody else has seen and to think what nobody has thought. And what is the motivation for research? Desire to face the challenge in solving the unsolved problems, and desire to be of service to the society. So any part of your basic research can get translated, and it can help the patient. So if you are doing a research in the lab, at the end, whatever publications we do, whatever citations you get, that is not enough. It should help the patients. And if you do some educational research, then it should help the students. So translational research is very, very important. That is bench to bedside. And this is the organization IIDR. It is the International Association of Dental Research, the biggest research organization in the world. So all the students and faculty, you should try and submit your papers and posters here, and you need to travel and you need to present, because I started presenting in IIDR in the year 2009. So for last 14-15 years, I have been presenting my papers and posters, and till date I am presenting. So before starting any research, better I would suggest, by my experience I am telling, better to first start with reviews. It may be a simple narrative review, or it may narrative review, that too writing a narrative review on some important novel topic, or systematic review on meta-analysis, or people write Cochrane reviews. Bibliometric analysis also you do. Bibliometric analysis is on one particular topic, you do an analysis and you present a paper. So initially it is better to start with the review. And once you do review, you find some gaps in the published literature. So that gaps you have to utilize, and then you have to frame your own research proposal, and then you need to execute the study. So better to start with reviews initially, even the students as well as the faculty who are not trained researchers. And research process, how it goes: first you need to define the problem, specify a particular research question, design the research properly. So designing the research is very, very important, because that is what the whole methodology is. Collect the data, adequate data, analyze the results properly, and then write the manuscript. So this is the whole process in research. Development of a research question. The first step in conducting clinical research is to formulate a clear and specific research question. So that is very, very important. Why you need to do the study, or what is the need for the doing the study, that is important. Because if many studies have been already published in the literature, the journals will not be keen to publish already published entity. So you should always need for the study is very, very important. Why you want to do the study, that question needs to be answered. And defining the objectives, try to keep initially as simple as possible. The more variables you include, the more difficult the research becomes initially. Get helps from your mentors, because when you start doing the research, especially the students, undergrad or postgrad students, get help from the mentors at this stage who are already publishing, or from your senior colleagues, and or from experienced researchers in your institute or from other institutes as well. In literature search, check once you get any idea after doing a thorough literature search, check to see if your idea is original. Because we feel, yes, this idea is very novel, but when you see, there will be so many articles already published on that particular topic. So check to see if your idea is original. Look for, try to get the full article, read all the key references, and most of these will be very important when you are trying to write the manuscript. So literature search is very, very important. So the postgraduate students, in their LD library dissertation, they need to do thorough literature search, and better try and publish that LD in the form of systematic review or meta-analysis. Because when you're spending so much time in doing that literature, better publish it. Choosing the studies design. The quality of the research data depends on several factors, including the appropriate design of the study. So the researcher must first get accustomed to the application of the various study designs. So there are many study designs which are available. So you should know, you want to do retrospective study, prospective study, right? Cross-sectional studies, longitudinal studies. So there are different study designs. So you need to and for clinical research, these are so many study designs. There are epidemiological studies, randomized control trials are very, very in demand these days. So there are many types of experiments which you can do. And first, identify the research area, design your research properly, carry out research, analyze the results, and publish the results. So this is the complete research cycle. And factors to be considered. Research topic selection is very, very important. So you have to spend a lot of time to and discussions before you select the research topic. Go and see if already such literature is already published or no. So identify the gaps in literature. Research methodology has to be very, very apt, because the journals these days, they look at the methodology. The methodology has to be very, very solid, because if your methodology is a bit flawed, the reviewers, because all the journals will send your manuscript to the best of the researchers in the world. So they will check for the methodology, and whatever you do in vitro in the lab, see that if possible, you can convert them into clinical trials later on. I will tell you about that. And interdisciplinary collaboration is very, very important. So maybe it is between oral pathology, oral medicine, oral surgery, oral radiology, or different aspects you need to definitely collaborate, because collaboration is the key for publication. That is what is according to my experience. So raw data. So any studies you do, experimental studies, have the raw data with you. So what is that? I will tell you in later part of this lecture. So there are 3 stages of publication. Before you start writing the manuscript, preparation of the manuscript, how you should prepare, and while submission. So these 3 you need to look for. Studies with good research methodology. Suppose your methodology is very sound and very apt, but still if novelty is not there, that research and that methodology or that article will go for a toss. So novelty is the key, and novelty with good research methodology only will get accepted these days. Journals reduce the priority of the articles which do not carry any significant translational value. So this is the one. Either if you lack novelty and if you don't have significant translation value, especially in our fields, then journals will definitely reject the manuscript. And there are so many. First, the journal used to get articles in hundreds, but nowadays they are getting in thousands. Where the journals used to get 500 submissions a year, now they are getting 4,000, 5,000 submissions. So they are very, very choosy. And now what is translation value? Translation value means any research you do which has clinical relevance. And in simple term, how does this research help the patient? That is what you need to see, and the journals will definitely see. And while preparing the manuscript, you need to look for these. So these are the key points which, according to my experience, I'm telling. You need to have a graphical abstract. The figures should be of very high resolution. And before you submit, see that you use the similarity index or plagiarism detection softwares like Authenticate and Turnitin. Language editing, you have to get it done before submitting, because a good research with poor write-up will again get rejected. A mediocre research with a very good writing and storyline may get accepted, may get. So, and reference citation managers you have to use. That is very, very important. And before you submit the manuscript, there is something called, which according to my experience, I'm telling you, it should be internally peer reviewed. Internally peer reviewed means journal will anyhow send to the peer reviewers. But before you submit, among your colleagues, share the manuscript, right, whom you trust, and let them give the feedback or comments, because certain things which you don't see, they may be able to identify the shortcomings of the manuscript, and then you can refine it, revise it, and then submit. So internal peer reviewing among yourself, among your collaborators or who are part of the study from the start, better share the manuscript and then get their comments, revise it, and then submit. That will avoid so many negativities or so many comments by the reviewers. And during submission of the manuscript, finding a journal is very, very important. People don't spend time in finding a right journal. So journal selection is very, very important. They have the manuscript, they want to submit it as fast as possible, or to the known journals they submit. It should not be like that. Find an apt journal. So journal selection is very important. Formatting of the manuscript. So formatting means according to the author guidelines. Every journal has a unique author guidelines. So format the manuscript according to the author guidelines, and before submitting, check whether it is an open access journal, it is a subscription based journal, or it is a hybrid open access. Hybrid means they allow both the with paid and without payment. So article processing with article processing charges and without. So that also you should see, an acceptance rate of that journal. All these points, key points, you need to see before you submit the manuscript. And I feel, according to my experience, depth of the investigation is very, very important, and the accuracy of the experiments, because these the reviewers will see, and how deep you have gone. Because these days, 10 years back or 15 years back, even oral pathology research on just histopathology with some immunohistochemical markers or just plain histopathology used to get accepted. But nowadays, the journals want more. They want histopathology, they want immunohistochemistry. Suppose you are doing research on human papilloma virus, right? HPV related. So they want even PCR data. So that is the way the depth of investigation is very, very important. Sometimes you may need to use ELISA, Western blot, flow cytometry, genomics, proteomics, mass spectrometry you may have to use. Sometimes now, apart from IPS, OPG, CBCTs, all these have to be, depth of investigation is very important, and accuracy of the experiments that the journals see. So sample size, sample size is very, very important. And decide your inclusion exclusion criteria, because journals will see what inclusion criteria is there for these patients to be selected and what exclusion criteria. So that is very, very important. And what is the power of the study? So statisticians provide the answer. So if you don't know better, consult a statistician before you start the study. Ask him, yes, I am planning to do this study. Tell me what sample size has to be used. So that is very, very important. The sample size determining your statistician can do, or if you are a trained statistician, that is good. Otherwise, better consult a statistician, determine the sample size, and then go. Because many articles I see which I review, the sample size is very, very less, and that is why many times we have to reject the manuscript because of the low sample size. And the power analysis you have to do. The statistical power is positively correlated with the size of the sample. So how to determine the power analysis? It is your statistician only will need to say and address it. So he will do the calculation. Small sample sizes have a greater chance of rejection. That is my personal experience as an author and as a reviewer also. So sometimes if there are if there is a sample size less, you need to give a proper or clear justification why the sample size is important. Suppose very rare lesions you are presenting, then you need to give justification why the sample size is less. And justification of the sample size should be mentioned in the paper to increase your chances of acceptance. If you don't justify why a sample size is less or why you have taken this less sample size, you can explain that, yes, I have done the experiments which are quite deep, right? I have used histopathology, I have used immunohistochemistry, I have done Western blot, I have done flow cytometry. So depth of investigation, more the depth of the investigation, you can explain because of this, my sample size was less. And it is recommended that researchers must have a prior idea of what they would expect to be scientifically meaningful difference before doing a power analysis. So for this sample size and power calculation, your statistician is the person, or biostatistician is the person who can help it. So adequacy of study, quality control is very, very important. You cannot compromise with the quality of your study. So quality control is important. Accurate measurements are very important. Compliance of cases and control. If you are doing a case control study, you need to follow up properly and see that the study is adequately blinded. Usually double-blind studies are more in demand. So the patient also doesn't know and the investigator also doesn't know, but there is an observer, a calibrator observer who will observe and help you guide. So that is double-blinded studies are more significant than single-blinded. So there are different types of blinding: unblinded, single-blinded, double-blinded. So double-blinded studies are very much in demand. So, and always explain that the observer was different from the investigator. So nowadays the journals look, and the observers have to be calibrated. So make it clear in the manuscript. So if the investigator is the same as the observer, this may not be accepted, as the journal's editors and reviewers could find such data as bias. So there should be no bias at all, because reviewers will look if there is any bias. And it should be specifically mentioned that the patients were assessed by trained observers who were unaware of the study group's identity. I am talking about clinical trials. And elimination of confounders. So suppose you are doing a study on, for example, water pipe smoking. So when you are doing a study on water pipe smoking, that is hookah or shisha, you cannot have the patients having habit. He has a smoking habit, he has alcohol habit, he is having this vaping or e-cigarette. If he has multiple habits, then that study will definitely get biased, and there are too many confounders. So if you're doing a study on particular cigarette smoking, means the patient should have the habit of smoking only. He should not have the other habits like water pipe smoking or cigar smoking or vaping. So he should not have those. So elimination of the confounders is very, very important. Studies with even a small sample size can be acceptable, I have told, if the depth in the methodology is adequate. So translating lab experiments into human clinical trials. So especially in oral pathology, oral medicine, oral surgery, we do studies and we use the cell lines. So nowadays, instead of cell lines, you can, suppose you are doing a study on oral cancer, take the biopsy, right, with the help of enzymatic digestion, create a single cell suspension of the biopsy tissue, and then try to do the experiment rather than using cell lines. Because this biopsy tissue, you know the age of the patient, you know the gender of the patient, and you know what habits that patient had. So it gives a real-time situation. So better if you're doing, you see that the other variables are not there, and better nowadays the journals don't give that importance when you're doing a study on cell lines. So how you translate basic research into clinical use? Primary culture should involve biopsy of the interested tissue from the patient whose complete medical history is known, including his or her habit history. So for such cases, there is higher chance of translating the results obtained from the primary culture into the clinical practice. So try to replicate as much as possible the real-time situation, and validate the study using multiple modalities. So one single, by doing only histopathology, you cannot do validation. So you may have to use immunohistochemistry, you may have to use ELISA, Western blot, RT-PCR, flow cytometry. So the more deep you go using the molecular tools, the acceptance, this is called validation of the sample, and the acceptance rate increases if you use multiple modalities, not one single modality. What we used to do, I mean, so few 10-15 years back, use one immunohistochemical marker, you study on 30 patients and you give the inference. That will not work these days, because nowadays the journals look for multiple markers, and depth in the investigation is very, very important, and even the sample size has to be big. And always in the article mention, if you are using some materials or anything, mention the manufacturer details, reagent composition, all these things, because the specific details you need to give, because the reviewer may look into the sensitivity and specificity of the tools used in the experiments. In patient-based experiments, I have told you, larger sample size and thorough in-depth validation needs to be done. Ethical clearance. So before you do any study, irrespective of it is human, animal, nowadays the journals are asking prospective, retrospective studies, any studies you do, nowadays the journals are asking for ethical clearance letter, and they are asking the copy. Not some few journals ask only for the ethical number, date and all. Some journals are asking literally the copy of the approved ethical letter. So before you start even the journals are asking ethical letters for even surveys these days. So better, before you start any study, better have a ethical clearance. Informed consent. So when patients are involved, patient written consent is very, very important. If you are publishing one single rare case, also patient consent is important. And if you have 4 to 5 rare cases together, you can publish as a case series. Single case, you can publish as a case report. 4 to 5 cases, case series. If you have 20-30 cases, then do an original research. But patient informed consent is very, very important. And preparation of the manuscript, you need to write the introduction, materials and methods, first the abstract with keywords, introduction, materials and methods, result, discussion, conclusion, all should be part of your paper. So these are the important 5 components which you have to see. And even after conclusion, you can write if any translation value is there, you write. If any clinical significance is there of a study, you can definitely mention. And even future prospects, what others can do, or what future you plan to do, you can definitely write the future avenue also. Maintain a proper structure. So the abstract should be comprehensive, which reflect the manuscript. Introduction should be, you should give an insight into the pre-existing literature, and also include the justification for choosing the topic. Why you want to do this study, that is very, very important. You need to mention. Methodology, I have told you, the materials and methods used in detail, you have to write. Unless the journal asks you to reduce the methodology because of the limitation of words, then only you reduce. But otherwise, in-depth detail you have to give about the methodology, because the reviewers will see the methodology and the result section. These two, they will focus. And standard protocols, the shortened section should give a false impression. Means if you write only 2-3 sentences in methodology, then it shows that you have not followed the standard protocol. So an author should cite the published articles. Means if you have feel that yes, this methodology you have followed of already published literature, better cite those articles also. So that will give the information to reviewer, yes, he has followed this particular methodology. Comprehensive representation of the results, the outcomes, what are there, you have to analyze it properly and represent more in the form of figures and tables with proper legends. Tell what is there in that table and figure, and give proper explanatory legends have to be there. So analysis of the data should be done properly with good figures and tables, not 20, 30. The representative figures and tables you need to include. If you include too many tables and figures, then they'll ask you to reduce or they will reject the manuscript. And signaling pathways are very, very important. Nowadays, what is there, how much is there, the journals don't want. They want to know how this has happened. Suppose oral cancer has happened. What is the pathway for it to occur? So how? The mechanism behind it, the journals want to know. And for that mechanism to tell, you need to do in-depth experiments. Signaling pathway studies are very, very vital. So the journal want to know the molecular pathway of the induced effect. The effect is there, but how this effect is taking place? And that you can do by doing molecular analysis. And it should have a thorough experimental model. The pathway model should be there. Collaboration is very, very important, because people don't collaborate. I have seen. So if you want a comprehensive research, suppose you are doing a research on artificial intelligence, you have to involve a person who has experience in AI. So you cannot so take his feedback and suggestion and then start the study. So multidisciplinary collaboration, you may have to include the engineers if you are doing some materials-based study. Who is a specialist in biomaterial engineers, you need to involve. So interdisciplinary collaboration is very, very important, and you should be open-minded. So when I started doing research, I collaborated with foreign professors from Hong Kong, from Europe and all. I used to invite them for such conferences, and then I built a collaboration. And interdisciplinary collaboration is very important. You have to be very open for collaboration. If you are not, then whatever data you have produced, it will remain into a laptop only. It will never see the light at the end of the day. So discussion, implication of results should be discussed, and how the results, what you have got, how they are similar with the pre-existing literature, how they are different from the pre-existing literature, you need to discuss. And conclusion, the insights determined from the research along with relevant suggestions should be mentioned, and conclude by telling what future perspectives could be done, or what, suppose you are not able to do genomic, proteomic, or transcriptomic analysis. So you can leave a note there that what future avenues the other authors can do and how can they take this experiment forward. Because the success of your research is not just by publishing, it is how many citations your article is receiving, and that shows that how many people you are using your research for doing their research. So that is what the is very, very important. Citations is very, very important. And whenever you submit an abstract, a graphical abstract is very, very important. So graphical abstract means it is a gist of the complete study. So if you, apart from the article, if you submit a graphical abstract, it will give a complete overview of what research you are doing. Then your chances of acceptance, manuscript acceptance will be high. So graphical abstract is a graphical, it is a summary of the methodology and results, and the chances of acceptance are very, very high. And the images what you use for graphical abstract has to be original from your own study. You cannot pick them from other articles from the available websites, right? So they have to be original. So effective use of figures and tables, also figures such as bar graphs, frequency histograms, scatter plots, drawings, maps can be used to represent the data, and descriptive, clear and concise legends should be included for tables and figures. So what that table represent, what that figure represent, it has to be crystal clear and simple. And always I see articles being submitted from the developing countries, or articles submitted from researchers who are very, very new, right? So the quality, resolution and size of the image should be taken care, because the quality of the image, suppose you have done a wonderful research, but if your image quality is very poor, the journals will again reject it. So when you suppose you are submitting some photo micrographs, so use a very good microscope, right? And the resolution of the image has to be very high quality. The size of the image should be according to the size recommended by the journals, and figures and tables should be numbered and should be cited in the main article. So quality and resolution is very, very important, where people fail to follow that. So many articles which are submitted, so what happens is usually we have to reject because the resolution of the image is very, very poor. Minimum 300 dpi high resolution images in JPEG or TIFF format you need to submit, or whatever the journal specifies. So softwares used for preparing the figures, usually I use BioRender. There is a software, some people use this Prism or GraphPad also. So BioRender, so it is a software available. Initially you can try for free, but if in free you have very less images. But if you pay them, monthly or yearly subscription is there, so you can use these images from BioRender to create your own images. So suppose you don't have an original image of your own, you can create one by using this software. And these are, if you use BioRender and submit a manuscript, then there will be no copyright issues. Copyright of the figures. Suppose if you have your original figures, well and good, but if you want some other figures from other published textbooks or articles, so you need to take prior permission from the publisher. Whoever has published the article, write to them and telling that I want to use this image or figure. And if they give permission, then only you can use. Otherwise, try to keep your figures as, suppose you are as original as possible. Suppose I'm writing a book chapter for Elsevier. So suppose I need a figure. So from Science Direct, I can seek the permission from Elsevier and take the copy from any published article or textbook from Science Direct. So if they give permission, use it. So permission has to be there. Raw data or data in brief, or it is called supplementary files. Nowadays, all journals are asking to submit the raw data files. So whatever experiments you do, there will be data generated. And that data, why the journals are asking? Because it will tell the date, time, and when the experiments were conducted. So always any experiments you do, how images are important, right? If softwares are used to run the experiments, so try to capture original images. If you are doing in some research laboratory, tell the technician, I need higher resolution images and along when you're collecting the images, collect the supplementary files also. These are called data in brief, because nowadays for molecular studies in biomedical sciences journals, all are asking supplementary files. If you don't have, then they will again reject the article. So for example, you have done some study using flow cytometry, that generates FCS files. So that files you need to submit to the journals. Journals will ask, because they want to know whether this study was really conducted, because that files will give the time, date of the experiment conducted. Cite latest references. So suppose the key article is 20, 30 year old, if you want to still use. But what latest research has been done, better cite the latest references if it is suiting your manuscript. Don't forcefully cite the latest references if the need is there, but cite latest references. The authors have to ensure that majority of the references are published in the last few years. So citing the latest references is very, very important. So citing references from high impact journal or Science Citation Index or Science Citation Index Expanded or Web of Science, PubMed or Scopus Index journals, try to cite articles from them. Or suppose you are submitting an article for a journal with an impact factor 2, to sometimes try to cite articles from impact factor 3, 4, 5. So because the higher the impact factor is there, sometimes the quality of the articles is good. So try to cite if it suits your study. And citing references from non-index journals means the journal doesn't have any indexing, neither it is in Scopus, PubMed or Web of Science, and you are citing, usually reviewers will not like you citing from a non-index journal, so your chances of acceptance will decrease. And language editing is also very, very important. So before you submit the manuscript, see that you get it edited from a professional English speaking. Some journals ask UK English, some ask US English, right? So when you submit articles with our own Asian or Indian English, so the journals may be not willing to accept the manuscript. So seek help of a professional language person who is editing. He may be an English teacher in your kid's school, or he may have done PhD in English, or he may be a professional. There are so many professional language editing companies these days. Seek help before submission. But if your language only is excellent, if your English is good, no need to get editing done. But if you feel language is mediocre, then better seek help from the professional language editing company. Titles should be catchy. Titles should be there, and which provides clues on the methodology, results, translational aspect of your study, little bit design of your study. So that component has to be there. A more scientific title has to be there, not an extravaganza title which is very hi-fi. You feel, oh, if I write this title, the journals will expect. No, it should be very, very scientific. Plagiarism detection software. So before submitting, I've told you, screen your manuscript. Sometimes the similarity index. See, plagiarism is very different from similarity index. Plagiarism is you're taking someone's ideas, copying someone's ideas and claiming it is your own is plagiarism. That is very different from similarity index. So similarity index, there are softwares like Authenticate and Turnitin softwares are there, where you need to scan your manuscript with these professional softwares, and suppose the similarity index is high, try and reduce the similarity index and then submit.
Doctor, you have another
most
5
impact
minutes.
factor.
Another 5 minutes.
Most other 5 minutes. Okay.
Yeah.
So most impact factor journals expect the overall similarity index to be less than 10%, and from a single article to 2 to 3%. This is not published anywhere. I am telling, according to my experience. So free plagiarism softwares don't use because they will not give the accurate data. And reference management system, use EndNote or Mendeley. That is very, very important. Your formatting will be accurate. You can format your references according to the style of the journal. That is called reference management system. And systematic reviews and meta-analysis are more in demand than the narrative reviews I have told you. So in systematic review, follow the PRISMA protocol. That is very, very important. If you don't mention, journals will not accept it. Then search strategy. Journals want to see this. Risk of bias tool, that is very, very important. Prospero registration, you need to register all your systematic reviews and meta-analysis in Prospero, otherwise the journals will not accept it. Okay. Then internal peer review, I have told you, this you need to do before submitting. Choosing the right journal, that is very, very important. Choose the right journal, that is important. And journal selection, the scope of the journal you need to see, and your aim of your research should match with the scope of the journal. So that is very important. And every publishing house has for journal finder. You put your abstract and keywords there, it will tell you which journal it is, whether it is open access or closed access, and what is the acceptance rate, everything you will get. Spam mails, you nowadays you get a lot of spam mails about submit your articles, you are being awarded and all. Don't believe on all those theories. Okay. And try to publish articles in Science Citation Index or Science Citation Index expanded journals. Clarity analytics. Be careful about predatory journals. Okay. So predatory journals, please don't submit because they will claim that they have an impact factor and all. Please don't believe. Always Clarivate Analytics, you have to go and check the impact factor. Article processing charges, some authors feel, oh, if I pay the article processing charges, my manuscript will get accepted and blah, blah. That is all. I don't believe in that concept. If your article is good only, the journals will accept. Even they are open access, they may be charging $3,000, $5,000 also. If your article is of poor quality, they will not accept it. So don't be under that myth. Reality is very, very different. Okay. Then open access journals, the peer reviewing is a bit fast, right? They charge a sum of money and they do faster peer review process, but they will definitely see the quality because they don't want to, because they have to publish, suppose 200 articles in a year and 2,000 submissions are there. They will choose the top 10% of the articles, though you are willing to pay the money. Formatting of the manuscript is very, very important before you submit. And reference citation manager you have to use. Author statement, nowadays all journals are asking the author statement, what each individual author has contributed. That author statement you need to mention. Okay. Then and see the author guidelines. You have to submit articles according to the author guidelines. Pre-submission inquiry, if you want to check with the editor whether your manuscript suits that journal, do pre-submission inquiry also. Cover letter, don't simply write 2-3 sentences and leave the cover letter. That is very, very wrong. So the cover letter of the journal should have concise statement highlighting the merits of your manuscript, the scope, how it suits the journal scope, and how it will and what translational value it has. So you need to mention in the cover letter. Okay. So lastly, to conclude, your research should be novel, should have translational value, should have good sample size, depth of investigation is very, very important, and language editing you have to do, similarity index check you have to do, scope of the journal is very, very important, and follow the journal guidelines. Don't believe anyone, if some people try to discourage you, don't bother. If one journal rejects, submit to second journal. Second journal rejects, go to the third journal. Sometimes even till date, I submit to 10 journals, and one journal sends you revision. See that you do thorough revisions and you submit, and your article may get accepted. Sometimes your article may get rejected in a low impact journal, and sometimes it may click in a high impact journal. So please don't leave trying, because as Thomson Edison told, that he failed so many times, but one day he succeeded. But he told that what I failed, it was my attempt. I learned from those failures. So you need to learn from the failures and never get depressed and bogged down if your article gets rejected, because rejection and acceptance is a part and parcel of any researcher's life. So don't get bogged down by rejection. Keep on submitting, keep on trying to different journals. And don't publish in predatory journals. And collaboration is very, very important. So anyone wishes to collaborate, they are more than welcome. So thank you, Pushpagiri College of Dental Sciences, for giving me an opportunity, and 5th Annual OOO Conclave for giving me an opportunity to present.
Thank you, Dr. Shankar.
So if anyone has any queries, please let me know.
Any questions from the audience? There is nothing in the chat box. Anyway, it was a brief, detailed introduction for the postgraduates or for the researchers. This is what exactly we also needed. And in India, we are into a surge of research. Now, there are a lot of
Yes.
funding. So it was a good detailed discussion or the lecture.
And since the time restriction is there, but I can take a full day lecture on how to publish.
I know. This is something where we are also lacking, because we need our postgraduates to know exactly the nitty-gritties.
I had 500 slides, so for last 5 days I was cutting those slides, and somehow I have come to 100.
There are some queries, I think, in the chat box. Someone has asked, please elaborate on novelty value.
Okay.
Novelty value, see, I cannot elaborate. What you have to do is you have to do a thorough literature. Suppose novel, for example, I'll give an example. See, there are many articles published in oral pathogens, smoking tobacco, chewing tobacco and all. So if you do research on electronic cigarette or vaping and check its effects on oral tissues, that is novel these days. So that will add novelty. The journals may be interested in taking articles on vaping or e-cigarette, because people feel e-cigarette is replacement for the regular cigarette. So that is one aspect of novelty. Lastly, it depends on your field of interest. Read the articles, go through Google Scholar, PubMed, Scopus, Medline, and check what research you are interested in. One simple example I gave was checking the effect of e-cigarette on oral tissues.
One more query is how to select a journal based on acceptance rate of the journal.
See, so for example, Elsevier publisher has Elsevier Finder Journal, right? So there you go. I'm giving an example. There you go, put your abstract, keywords, copy paste it and put it there. So once you put the abstract there, submit it, then you will get 40-50 journals, list of journals. It will tell this journal is gold open access, this is closed access, this is hybrid open access journal. That is one. Next, it will give you the acceptance rate. It is 10%, 20%, 30% acceptance rate they will mention. They will also mention whether it is subscription based and whether your abstract is suiting that particular journal. That also some 10-15 journals list they will give. And then you choose according to your abstract, according to aim and objective, what is the scope of the journal, then go and submit. So even Sage has this, I think even Springer Nature has, all top publishers, European and American publishers have this facility. And please don't fall for call for paper, or they'll email you, you have won an award because of your latest published article. That is all crap. Don't believe this. I have 100, 200 emails like that. And sometimes because of this crap, sometimes I miss important emails because there is so much crap being generated and emailed to you in your inbox. And you are invited as a speaker for this conference and all. Please don't believe on all those things. Just because high impact journal and all, they will not bother to invite anyone. It is you should put an effort to go to them. If you are thirsty, you have to go to the well. The well will not come to you.
Thank you, Dr. Shankar. There's one more question they were asking, that how to cite the methodology of a standard machines when you're using for your methodology. So I don't know what do they mean.
Means they're telling, suppose try to elaborate your methodology in detail. Suppose the reviewers or the journals tell, your manuscript has to be restricted to 3,000 words or 4,000 words only. You need to reduce the length of your methodology. That time, standard methodology, what you used or what is your
machine
main article, what you have used to design your study, you can cite that article. But novelty has to be there in what you are doing, and the translational value has to be there in your study.
Thank you, Doctor.
Yeah, and everyone here, please be open. July I'll be coming to India after 4 years. I was not able to come because of this COVID. Anyone is interested anytime, please do contact me. My email ID is there. Anywhere you put my name in PubMed, Google, anywhere you will get. I am corresponding author of so many journals. So you'll get my email ID. Please email and contact if you need any suggestions. I'm more than happy to help the younger budding dentists as well as the faculty who want to make a career out of research. So from India, I moved to Saudi Arabia. From Saudi Arabia, I moved to US. So it is a big journey of over a decade. And because of my research, publications, citations only, I've got a American green card, me and my family, and I have settled in US only because of my passion for research, publications, citations, reviewing, being on the editorial board of big journals. So through that only I have come here. So, and when I started doing research, I did not know I will go so far, but I have come so far because of single focused patience, perseverance, focused. You have to be very focused. Don't bother about anyone. People will criticize you. People will make fun of you. People will laugh at you. When I started doing research, they used to make fun of me. I did not bother. I kept my focus. And today I am here sitting in US.
Thank you, doctor. Thank you. Nice of you to say that. It's a motivation also.
Don't
inspiration and motivation for the young dentists who are coming out freshly. They are looking for options and they always prefer to go to clinicals because they think that's the only way to gain fame, name.
No, you can make a career out of research, but you have to diversify your research. You cannot tell, oh, I'll do only histopathology and I'll make a career of it. No, apart from histopathology, yes, it is our forte. You have to you have to learn skills, especially life sciences. In America, I have seen, what I observed is, if you know flow cytometry, if you know PCR, if you know immunohistochemistry, and if you know ELISA, Western blot, all these lab-based experiments, if you have trained yourself, you will definitely get good jobs in US. Pharmaceutical industry will hire biotechnology companies. There are thousands of companies here based in US who are looking for the right candidate. So you have to diversify your research. You cannot stick to basics and expect that some miracle will happen. With time, I have diversified. Initially, if you see my papers, 2011-12, I should do histopathology. Then I came to immunohistochemistry. Then immunohistochemistry with PCR. Then flow cytometry, ELISA, Western blot. Then I have done genomics, proteomics, transcriptomics. All I have added. Then only you can come so far. Then only your manuscripts will get accepted in good journals.
Thank you.
Thank you, sir.
Yeah. Thank you so much. And if it has motivated even 10% of the audience here to do research, I will be very happy and honored.
My sincere appreciation to Professor Dr. Shankar Gowda, sir, for enlightening us on this very informative topic. And I would also like to thank our moderators for the session, Professor Dr. Baby John, sir, and Professor Dr. Jayanti ma'am. Kindly accept our token of appreciation. First, I would like to invite our speaker, Dr. Shankar Gowda Patil, sir, to accept the token of appreciation. Now I invite Dr. Baby John, sir, to accept the token of appreciation.
Thank you.
And I also would like to invite Dr. Jayanti ma'am to accept the token of appreciation.
Thank you so much for the opportunity.
Thank you so much. And if possible, do mail the certificate if possible, so that it will be for my records.
Sure, sir, we will mail it.
Thank you so much for your patience here.
Now I'd like to welcome our speaker for the third session, Dr. Sutish Manoharan, Consultant Oncosurgeon, Malabar Cancer Research Center, to present on the topic Diagnosis and Treatment Planning for Oral Cancer. I would also like to welcome Professor Dr. Ethan Thomas, sir, and Professor Dr. S. Sunil as moderators for the session. Professor Dr. Ethan Thomas, Head of Department Oral and Maxillofacial Surgery, Pushpagiri College of Dental Sciences. Welcome, sir. Dr. S. Sunil, Professor and Head of the Department, Oral and Maxillofacial Pathology, Vice Principal Academics of Pushpagiri College of Dental Sciences. Welcome, sir. I would like to request Dr. Ethan Thomas, sir, to introduce the speaker, Dr. Satish Manohar, to the session.
Thank you. Thank you, Dr. Mika. Well, now let's move on with the last lecture session of today. Now we have with us a young, dynamic oncosurgeon, Dr. Satish Manoharan. It is indeed my pride and privilege to introduce him because a very good friend of mine. I've seen him grow from a student to a very flourishing, successful oncosurgeon where he's working now. He's actually finished his post-graduation in oral and maxillofacial surgery from Government Dental College, Kottayam, the prestigious institute in 2012. Then he went on to do his fellowship in International Board of Oral and Maxillofacial Surgeons. Then before that, he went ahead to do his fellowship in head and neck oncosurgery from the prestigious Malabar Cancer Center in 2014. In 2018, he got his fellowship in International Board of Oral and Maxillofacial Surgery. And then he's a very successful practitioner. He's actually working as a consultant in MVR Cancer Center and Research Center. Over to you, Sudhish. He's going to speak about the diagnosis and treatment planning in oral cancer. You have 45 minutes from now. Thank you.
Thank you, Ipan sir, for your kind words. Shall I share my screen?
Please do.
Is my screen visible, sir?
Very clear.
Yes.
Just kindly move to the slideshow.
Yeah. Yeah. Thank you. Thank you, Ipan sir, and the organizers of OOO. It's a great opportunity for me to present a lecture on oral cancer. I'll be talking briefly on the diagnosis and treatment planning in oral cancer, which is very, very important in its management. And I'll try to make it very simple and crisp so that all the O's like oral pathology, oral medicine, and maxillofacial surgery people can comprehend the concepts. And for the PGs who has attended the great masterclass, PG masterclass at Pushpagiri 2 weeks back, it will be more or less same. The topic was same. I presented there also. The topic was same. And it will be a repetition for them. So I'll try to, let me start with my presentation. Before starting, let me thank or pay my tribute to my great teachers, Dr. George Varghese, who was my PG teacher, Sajid sir, who was my head and neck mentor, and Sadishan sir, who is the director of Malabar Cancer Center. These people were the pillars of my career. And apart from them, there are many others which the list is very long. To mention a few, Dr. Srila Jayakumar, who was my very dear teacher, who stood with me along during my difficult times. Dr. Beena, who was the principal of Government Dental College, Kottayam. Two people who helped me a lot. And Ipan sir, though he didn't teach me anything, in my college days, but he was there right from my first year BDS onwards. He was the shining star of Kottayam, and he was there with us, and I've been with him for many ventures. So thank you. So I'll be discussing this topic under three major sections. First is the basic incidence and epidemiology of oral cancer, and how to diagnose a case, whenever a case comes to you, how to go through the case, and how to plan a treatment. So I'll be discussing under these topics. So to begin with, India tops the list in the number of or in the incidence of oral cancer, amounting approximately 36% of all the oral cancer diagnosed globally. And when it's come to Indian incidence, oral cancer is the most common cancer in Indian men, and fourth most common cancer in Indian women. And all this is attributed to the increased usage of tobacco. So diagnosis, whenever a patient comes to you, to your OPD with an oral lesion, how to examine the patient, how to evaluate the patient, when to take a biopsy or how to take a biopsy, what imaging should you do to assess the lesion, and how to stage the lesion. So we'll discuss these aspects first. So oral cavity is divided into 7 subsites, namely the lip, upper and lower lips, tongue, floor of the mouth, upper and lower gingiva or the alveolus, upper and lower alveolus, buccal mucosa, retromolar trigon, and hard palate. So these subsites the oral cavity is divided into these subsites, and the lesion is also staged according to these subsites. So subsites was the subsite wise distribution. Tongue and floor of the mouth contributes to most of the oral cancer, like around 43% of the all oral cancer is confined to tongue, and second is the oral tongue. Second is the floor of the mouth, and buccal mucosa and lower alveolus comes later. But this is the global data. But in India, the bucco-alveolar complex, namely the buccal mucosa, upper and lower alveolus, this is called the bucco-alveolar complex. That is the most common subsite in India. So, how to evaluate a patient? So, evaluation of oral cancer consists of examination of the oral cavity as well as the examination of the neck. So, oral cavity examination is very simple. There is an 8-step examination of the oral cavity. So, first you start with the examination of the upper lip and the upper labial mucosa and the upper labial sulcus, and along with that the upper alveolus, anterior part of the upper alveolus. Then moving on to the buccal mucosa, upper GBS and lower GBS, upper alveolus and lower alveolus, tongue, floor of the mouth, and the hard palate. This is how you go around. So this is, you don't have to like strictly follow this this systematic way, but the idea is to assess all the part of the oral cavity, to cover all the subsites of oral cavity which I mentioned. So you should examine the patient under a good light and with a gloves. You don't just use a mouth mirror and just assess the oral cavity and go. No, that is not the way to examine the oral cavity. You should palpate each and every subsites of the oral cavity and look for certain warning signs. What are the warning signs? You examine the oral cavity and what are you looking for? So there are certain warning signs which can point towards an oral cancer. So, for example, a white or red or a mixed red-white patch anywhere in the oral cavity, an ulcer which is persisting for more than 2 weeks or 2 to 3 weeks, any firm to hard mass anywhere in the oral cavity, any firm, for example, the texture of the oral mucosa is changed, a roughness or a leathery feeling. So these could be a malignancy or initial stage of malignancy. And an unexplained loose tooth or gum bleeding, which is not associated with periodontitis. This is very, very important because most often we get patients with who went to a dentist for a loose tooth. Dentist did an dental extraction, and sent the patient off. And the patient later come up with a very advanced malignancy of the jaws. So this is a very common scenario. And whenever you get a patient with a loose tooth or a gum bleeding, you should rule out periodontitis first. That is, of course, that is the first thing to do. And in the absence of a gingivitis or a periodontitis, you should evaluate the cause of loosening of the teeth. That is very important. So unless you, you should do an imaging to look for any bone loss or bone erosion. If you don't do that, you just do an extraction of the loose tooth and send the patient away. The patient might come back with a very advanced malignancy because the early stages of lesions of lower alveolus or upper alveolus present with a loose tooth. So that is very important. And you should look for any deformities of the jaw. So I will take you through a few pictures of these warning signs. Here you can see a small white lesion or a spread homogeneous white lesion on the floor of the mouth. Here you can see a mixed red-white lesion. This either could be a potentially malignant disorder or an early invasive squamous cell carcinoma. So these are the initial stages. Or you can see a non-healing ulcer anywhere in the oral cavity or a proliferative lesion. Or you can see a very infiltrative, this is a very advanced infiltrative lesion of the floor of the mouth. Or you can see a proliferative lesion anywhere in the palate or upper alveolus or lower alveolus. So these are the certain clinical pictures of oral cavity. So what to do? You end up with these kind of lesions. What to do? So in that lesion, you have to take a biopsy. That is very, very important. So when to take a biopsy and where to take a biopsy, that is again another important thing. For example, this lesion, a homogeneous white patch, could be a leukoplakia. So most often we will be tempted to treat this patient with multivitamins. So that is not a good thing to do, because it is always better to do a biopsy before starting a medical management. Why? Because there are certain prognostic factors or risk factors for malignant transformation of oral potentially malignant disorder. So few risk factors are like if the lesion is more than 2 centimeters, exposure to tobacco, or the lesion involvement of tongue or floor of the mouth are certain indicators of malignant risk of malignant transformation of oral potentially malignant disorders. But the most potent or most worst prognostic indicator is the presence of dysplasia. If the patient is having dysplasia, that means there is a high chance of malignant transformation of the lesion in future. So dysplasia you can only evaluate under a histopathology evaluation. So always do a biopsy before managing a patient with oral potentially malignant disorder. So where to take a biopsy? So lesions like this, homogeneous leukoplakia lesion, I always suggest to take biopsy from multiple sites to look for any changes. A lesion like this, a mixed red white lesion, these are more dangerous than a leukoplakia. In that case, you take from this reddish patch, reddish area of the lesion. So that is how you should plan an oral potentially malignant disorder. Now, once you examine the oral cavity, you found a lesion which you suspect a malignancy. Now, examination of neck is very, very important. Why? Because oral squamous cell carcinoma metastasizes through lymphatic channels. So, lymph node enlargement is another important. And in presence of lymph node will change. We will reduce the prognosis by 50% by itself. So, the presence of lymph node means the prognosis reduced by 50%. So examination of neck and treatment of neck is very important in oral cavity cancers. So examination of neck, I cannot demonstrate because it's an online meeting. So still, the cervical lymph node stations are divided into 7 groups, level 1 to level 7. And as far as oral cavity cancers are concerned, level 1 to 5 are important. Level 1, 2, 3, 4, and 5 are important as far as oral cavity cancers are concerned. So, examination of level 1 and level 1B, level 1A and 1B are examined from standing from in front of the patient, and level 2, 3, and 4, level 2, 3, 4, and 5 are examined standing behind the patient like this, examining along the sternocleidomastoid. That is how you examine level 2, 3, 4, and 5. So I'm not going into the depth of examination of the neck. And once you do a clinical evaluation, examination of oral cavity and neck, next thing you have to do is do a biopsy. You should get a tissue diagnosis before starting a cancer treatment. So tissue biopsy is one thing, and second is a FNAC or cervical node. You need, if you have a positive biopsy report, you don't have to do an FNAC. You don't need both biopsy as well as FNAC. Either one is enough. So if you get a biopsy, that is enough for a diagnosis. Core needle biopsy or true cut biopsy, we don't do a true cut biopsy routinely for oral cavity cancers. But when you get a deeper tumors of the neck, you might go for a true cut biopsy or an image guided true cut biopsy. So how to take a biopsy is very, very important. So always take these are very simple things, but very important. Always take the biopsy from the edge of the tumor, so that you will include a bit of normal tissue along with the lesion, so that the pathologist can compare the lesion with the normal mucosa. And the biopsy should be deep enough to include the connective tissue as well. That is very important. That is where most of the general physicians go wrong. Why? Because for a pathologist to give a report or diagnose the specimen as a malignancy, they should be able to see the tumor cells in the connective tissue. You all know that mucosa is divided into epithelium and a connective tissue and a basement membrane in between. The epithelium and the connective tissue are divided by the basement membrane. So an oral lesion becomes a squamous cell carcinoma only when the tumor crosses the basement membrane and reaches the connective tissue. So the biopsy should include biopsy should be deep enough to include the connective tissue as well, so that you will get a report as invasive squamous cell carcinoma. If you end up in superficial biopsy like this, what happens is either you will get a report like a hyperplastic squamous epithelium with dysplasia or squamous cell carcinoma in situ. These are the reports that you get. So you cannot blame the pathologist for that. The blame is on the surgeon side because the biopsy was not deep enough. That is very, very important. And another very important thing is never ever do an excision biopsy if you are suspecting an oral cancer. Why? Because our old teaching is what? If the tumor is less than 2 centimeters, go for excision biopsy. If the tumor is more than 2 centimeters, go for incision biopsy. That is wrong when you are dealing with an oral cancer. Because the treatment of oral cancer is wide local excision. Wide local excision means you have to give a margin of 1 centimeter clinically. Clinical margin of 1 centimeter all around the tumor to get a proper clearance, and you should get a microscopic clearance of 5 millimeters. So you take 1 millimeter extra tissue to get a microscopic clearance of 5 millimeters. So that is called wide local excision. So if you do an excision biopsy upfront, what happens is you do an excision biopsy, you get the report after 1 week, and you refer the patient to an oncology center, and the patient is evaluated at oncology center. You have to go, the patient will go for imaging, all those things, and it will take minimum 2 to 3 weeks for the patient to reach the operation table. So what happens? This is one of my cases where a dental surgeon did an excision biopsy of a small buccal mucosal lesion. So all what I have is a scar with a surrounding fibrosis. So where do I do the surgery? I'm blinded from the actual lesion. So in such scenario, what we do is we take the scar as a lesion and give 1 centimeter margin to the scar, which is actually removing excessive tissue unnecessarily. We don't know how much we are removing. It's difficult to assess the depth of the lesion. So never ever do an excision biopsy if you are suspecting an oral cancer. That is very, very important thing when you consider biopsy. So I hope that is clear. Now we'll come to the imaging. So there are different types of imaging when it comes to oral cancer, starting with the plain X-rays, ultrasound of neck, CT scan, MRI scan, PET scan. So we are spoiled with the amount of technologies that we have. So we have CT, MRI, ultrasound, PET scan. So which imaging modality to take? We often get cases from the other colleges, like especially dental colleges. They do a biopsy, they diagnose it as oral cancer. They do an OPG, they do a CPC or CBCT or ultrasound. And the patient come with all these reports. Usually, most of the times these images are not useful. For example, OPG. OPG is not not a useful imaging modality in our in oral cancer management. So don't go for an OPG unless it is very important. So how I will give you some guidelines how to choose. And if at all you are taking image, what image to take? So for example, the oral cavity can be divided into lateral and midline components. Okay, so lateral component means the upper alveolus, lower alveolus, upper and lower gingival sulcus, retromolar trigon, and the buccal mucosa. So this constitutes the bucco-alveolar complex. So or the lateral part of the oral cavity. For the lateralized lesions, always go for CT scan. So CT scan for buccal mucosa, upper and lower alveolus, upper and lower gingival sulcus, and retromolar trigon. So CT scan will give the best images. If the lesion is located in the midline, for example, the tongue, floor of the mouth, and the soft palate, these are more or less soft tissue structures. In such cases, it is better to go for a MRI scan, except the hard palate. Again, hard palate, it is a bony structure, and in such cases, you go for CT scan. Otherwise, midline structures, MRI scan is the treatment imaging modality of choice. So to summarize that, CT scan, you choose CT scan for buccal mucosa, upper and lower alveolus lesions, hard palate, and the retromolar trigon. For tongue, floor of the mouth, and soft palate lesions, you go for MRI scan. And for cervical nodes, evaluation of cervical nodes, ultrasound of neck is the most useful imaging. But again, if you have if you're going for a CT scan upfront, if you have lesion of the lower alveolus and you are suggesting a CT scan, you take a CT scan of neck also. So in such cases, the neck is already covered in CT scan, so you don't have to go for an ultrasound scan. So again, next is the metastatic workup. So oral cancer, the most common site of metastasis, distant metastasis of oral cancer is the lung, followed by liver and bone. So brain, it is very, very rare to have a brain metastasis from any head and neck tumor, but it can happen very rarely. So lung, liver and bone are the most common sites of distant metastasis. So to evaluate this, either you can go for a chest X-ray or a CT thorax. So again, if you have a buccoalveolar complex lesion, a single CT neck and thorax is the only imaging model that you need. It will cover everything that you need. CT, neck and thorax. CT, neck and thorax will cover from the skull base to the liver. So that will cover the whole thing that you're looking for. So you don't have to go for you don't have to go do a CT scan, plus an ultrasound scan, plus an OPG. That is not necessary. A single CT, neck and thorax. Contrast enhanced CT, neck and thorax will suffice most of the cases. For advanced tongue and floor of the mouth lesion, you might have to go for an MRI scan of the neck and the CT thorax of the CT thorax to assess the lungs. So that is how you plan for imaging in an oral cancer. PET scan, again, it is not a routine investigation for head and neck cancer. You don't have to do a PET scan for all oral cancer, but there are certain scenarios where you will suggest a PET scan. One is the patient has any signs or symptoms of distant metastasis. For example, if the patient is complaining of vague back pain on and off, where you suspect in an advanced oral cavity cancer. So in such cases, you might suggest a PET scan or a CT. You did a CT or MRI scan, which becomes inconclusive. Or for example, a CT scan shows a suspicious node, a suspicious lesion in the lung, which they are not very sure, or a lighted lesion in the cervical vertebra, which again they are not very sure. They cannot conclude it as a malignancy or not. Such cases, you can complement the CT images with a PET scan. Or a recurrent case, you have a large recurrence. In such cases, you suspect there could be a distant metastasis. In such cases, you can go for a PET scan or to assess the treatment resource. You did a comprehensive treatment like a surgery followed by radiation, chemo radiation. Maybe after 6 months, the patient is complaining of severe pain somewhere where clinically it is difficult to detect. Such cases, again, you can go for a PET scan. Otherwise, a routine PET scan does not stands as a routine investigation for head and neck cancer evaluation. Staging is very, very important. There are different aims. Why do you stage? To quantify that is to quantify the cancer. This will help in planning the treatment. It will give an indication for prognosis because the prognosis of stage 1 differs from prognosis of stage 4. Comparison of treatment results of comparison of treatment results of either different centers or different treatment modalities, and facilitate exchange of information between treatment centers. So these are the aims of staging. And again, aims there are the TNM staging is the most common or most followed staging system in oncology. And there are certain different types of TNM system like CTNM, that is the clinical staging system. Clinical means you do a clinical evaluation and imaging. After a clinical evaluation and imaging, you stage disease. That is called clinical TNM staging. Pathological TNM staging means you do a surgery for oncology. You do a wide localization and neck dissection, and the final pathology reports come. And based on that pathology report, you restage disease. That is called pathological staging. That is PTNM. Our TNM is residual tumor after treatment or a recurrence. Why TNM? It is a restaging after neoadjuvant chemotherapy. What is neoadjuvant chemotherapy? That we will discuss when we discuss the treatment part. So after neoadjuvant chemotherapy, you stage a YTNM, and ATNM staged after when you diagnose a cancer during an autopsy. Staging, if you want to understand the staging, you should read this textbook. AGCC Cancer Staging Manual. That is how you understand the staging. But for your exam purpose, or you just want to mug up the staging, you can take it from any websites, or you can in our textbooks. You can just. But AGCC Staging Manual you should read to understand the concepts of staging. That is very important. It is not like you do the T1 and 2 and 3. No, that is not how you learn staging. You should understand the concepts of staging, and therefore to understand you should read this textbook. Staging, I'm not going to elaborate on staging, but I'll give a brief idea of how to stage a disease. T1, any tumor which is less than 2 centimeter is T1, or depth less than 5 millimeters, it is T1. Any tumor which is more than 2 centimeter but not more than 4, that is 2 to 4 centimeter, it is T2, and depth should be less than 10 millimeter. And lesion more than 4 centimeter.
Dr. Sudesh.
Yes, sir.
Hello, Doctor. Yeah, you have another 20 minutes. You have another
20 minutes. Yes, sir.
Yeah, no
yes,
problem.
Sir. Yeah, sure. So more than lesion more than 4 centimeter is T3. So T4A is when the lesion involves the bone, cortical bone of mandible or maxilla, skin of the face, or size more than 4 centimeter and depth is more than 10 millimeter. Then it is staged as T4A. T4B means if the again these are the pictures of T4A, like involving the lower alveolus or the maxilla or the skin of the face. These are T4A lesions. T4B means a tumor involving the masticator space or the pterygoid plates or the skull base, or in cases internal cataract. These are the cases where we stage as T4B. This is an example of T4B presenting with risks. Cervical node, again, I'm not going to into depth of the staging system. You can read from the staging manual. Just understand that based on the number of the node, size of the node, and the laterality of the nodes, the staging is stages N1, N2, and N3. So again, this staging is difficult to understand. What I suggest is you take a screenshot of the staging system in your mobile phone and keep it with you, so that whenever a patient comes, that is how I learn. So whenever the patient comes with oral cancer, you assess the patient and look into your screenshot and learn the staging. That is how you can learn the staging system rather than mugging up from your textbook. So but at least you should be able to divide the whole lesion into early stage disease or an advanced stage disease. For example, like stage 1 or stage 2 disease is called an early stage, and stage 3, stage 4 is an advanced stage. So why? Because I will tell you later. Okay. So any lesion which is less than 4 centimeter size and not involving the bone or skin, and without a lymph node enlargement, and without a trismus. If all these parameters meets, that means the lesion is either stage 1 or stage 2, and that is an early stage disease. For advanced stage disease, if any disease which is more than 4 centimeter in size, or involving bone or skin, or without any lymph node involvement, or with trismus, if any of these features are present, that means it is either stage 3 or stage 4. That is an advanced stage disease. As a clinician, you should be able to at least differentiate between early stage disease and advanced stage disease. So coming to the last part of our discussion, that is treatment planning. So there are 3 different treatment modalities, that is surgery, radiotherapy, chemotherapy. So how to treat? So whether you do surgery, when to give a radiotherapy, when to give a chemotherapy, what is the choice of treatment, what is the sequence of whether to do surgery first or radiotherapy first. So these things matters. So as we have the cancer treatment starts from long back, and there are a lot of new modalities of treatment, and we are now standing in the era of gene therapy and immunotherapy. But unfortunately, or as far as oral cavity is concerned, the surgery remains the mainstay of treatment in oral cancer. And the choice of treatment, as I already told, why you should differentiate between an early disease and advanced stage. For a stage 1 or stage 2 disease, that is early stage disease, the treatment is single modality treatment by either surgery or radiotherapy. We always prefer surgery as a treatment modality because it has got a better survival compared to radiotherapy, and the morbidity is less. So surgery is preferred over radiotherapy for early stage oral cavity cancers. For stage 3 or stage 4, that is advanced disease, you need a multi-modality treatment, that is surgery followed by adjunct radiotherapy or adjunct chemotherapy. So again, the treatment, it's divided into three basically. There is something called definitive treatment. That is any treatment done to remove the disease from your body. That is called definitive treatment. It can be surgery or radiotherapy. Any treatment that is given before this definitive treatment is called neo-adjuvant therapy. That is, for example, you have a large disease. In that case, where the surgery is not feasible, in that case, you can give 2 or 3 cycles of chemotherapy as a neoadjuvant treatment. Then downsize the disease, then do the surgery. So that is neoadjuvant therapy, then definitive therapy. Any treatment that is given after definitive treatment is called adjuvant therapy. That is, you do a surgery, the surgery is advanced stage, you give radiotherapy after surgery. That is called adjuvant radiotherapy. So neoadjuvant therapy, definitive therapy, and adjuvant therapy. So management of neck is again another very important topic. It is a very last topic. I will make it very, very brief. There are three ways of treating the neck. Either you keep the patient under observation, or you can do a selective neck dissection or a comprehensive neck dissection. Selective neck dissection means, I told there are 5 levels of lymph node stations. You remove 1, 2, or 3 lymph node stations. That is called selective. You are not removing the whole lymph nodes. That is called selective neck dissection. And if you remove all the 5 levels, that is called comprehensive neck dissection. I'm not going into the details of these different techniques because neck dissection itself is a one-day CME. So I'm not going into details of different types of neck dissection in today's session. You should understand the concepts of occult metastasis. What is occult metastasis? Occult metastasis is you evaluate the patient, clinical and radiological. You take that as N0 neck. That is, there is no lymph node involvement, and you do a surgery. And the final report comes as node positive. That is, the node was hidden. You could not identify the node before surgery. That is called occult metastasis. So that is very important. There is a very landmark paper by Spiro where he found that where he compared the incidence of occult metastasis compared to depth of invasion. When the depth of invasion is less than 2 millimeter, the incidence of occult metastasis is less than 7%. And when it goes beyond 2 millimeter, the incidence of occult metastasis is 25% and 41%. And as a rule, if the risk of occult metastasis is more than 15%, you have to do a neck dissection. So that is why we do neck dissection in all the oral cavity cases. For very small lesions, you might keep the neck under observation, but all other cases you don't. This is another landmark paper from India that is by Anil De Cruz, that he compared patients who underwent neck dissection and whose neck were kept under observation. So neck dissection versus observation, and he found that doing neck dissection on oral cavity cancers will improve the survival of the patient. So neck dissection is a standard treatment for all oral cavity cancers. Adjunct treatment, again, there are 5 indications for adjunct radiotherapy. That is 1, T3, T4 disease, node positive disease, perineural invasion, lymphovascular emboli, and closed margin. So such cases, when these factors are present, that means there is an increased risk of locoregional recurrence. That means that patient requires adjunct radiotherapy. And when there are positive margins or extracapsular spread in the nodes, that means the risk of distant metastasis increases. So in that cases, you have to add chemotherapy as well. So adjunct chemotherapy. So these are the different 2 modalities of adjunct therapies in oral cavity cancers: adjunct radiotherapy and adjunct chemotherapy, and these are the indications. Now, if all these things are negative, all what is needed is a surgery. Wide localization and neck dissection is what is needed for treatment. So my last slide, the treatment algorithm. This is from the NCCN guidelines. So you have I'll summarize all the treatment thing in this page. Okay. So for primary T1, T2, N0, that is stage 1 or stage 2 disease, the primary treatment will be surgery. Surgery will be wide localization and neck dissection, and you review the pathology report after surgery. And if there are any pathology risk factors like this, any of these risk factors are present, then you have to go for adjunct radiotherapy. or chemoradiation. If there are no risk factors, then you can keep the patient under follow-up. For a T1, T2, but in node positive disease. Node positive disease, again, you have to do a surgery first, followed by radiotherapy. For advanced T3, T4A, again, of course, you have to do a surgery followed by chemotherapy, followed by chemoradiation. That is how. So what you have to understand is, for early stage disease, it is single modality treatment by either surgery or radiotherapy. Surgery is preferred over radiotherapy. For advanced stage diseases, it is multimodality treatment, that is surgery followed by adjunct therapy. To summarize, early diagnosis and early intervention are the key factors to improve the outcome of oral cancer. For diagnosis, biopsy is the gold standard, and never ever do an excision biopsy because of the reasons that I already discussed. Imaging, CT or MRI based on the subsite which is involved, and staging is based on the AJCC 8th edition currently. And the treatment, again, surgery is the preferred modality of treatment, and adjunct treatment will be based on the risk factors. I have a YouTube channel where I demonstrate the surgical techniques, different surgical techniques in oral cancer. If surgeons, if you are interested in understanding the surgical steps, you can always log into this channel. And yeah. Thank you very much. I'm ready to take questions.
Thank you, Dr. Sudhish, for that wonderful presentation as always. Yeah, we have covered the basics of diagnosis in oral and maxillofacial cancers, and that is something which is very much interesting and very passionate to you also. Now, do we have any questions in the chat box? I don't see any. Yeah, I can see a question here. Sudhish, can you please explain about sentinel node biopsy?
Yeah, that is a very good question. Sentinel node biopsy is like the neck dissection. First, you should understand the concept of neck dissection before you go for sentinel node biopsy. Neck dissection initially it was like you do a radical neck dissection for all the oral cavity cancer. Radical neck dissection means you remove all the lymph nodes, sternocleidomastoid, spinal axis nerve, internal jugular vein. So it is a very morbid procedure doing a radical neck dissection previously. So, and as the evidences came out, it came out like you don't have to do any. You don't have to remove all these structures. You can preserve sternocleidomastoid and IJV and spinal axis nerve if it is uninvolved. So then that is where the term comprehensive neck dissection or selective neck dissection came. So and again we came down like you don't have to remove all the level 5 lymph nodes. You can preserve level 4, level 5. That is where selective neck dissection came. Now the people are thinking like whether to do neck dissection at all if there is no lymph node involvement. So, but there are chances of occult metastasis. So if you can identify whether occult metastasis is there or not, then you can avoid neck dissection. That is the question. So what they do is they inject a dye on the primary tumor. For example, you have a tumor on the tongue. For example, a T1 tumor on the tongue. What they do is we inject dye around the tumor and let the dye go to the nodal basin. For example, the primary nodal station is level 1B or level 2. Those are the the primary draining stations of oral cavity. So, and we open the neck small. We put a small incision in the neck, and we identify for this node with this dye. So the color will be changed. So we take that node alone and send for frozen section for histopathology examination and look for metastasis. If the node is negative, then you can keep the neck under observation. If the node is positive, then you proceed with neck dissection. That is the concept of sentinel node biopsy. But it is not as it is a very useful and useful technique that is used in other subsets like breast cancer. But in head and neck cancer or oral cavity cancer, it is the evidence is not that good when it comes to survival. So we don't routinely practice sentinel node biopsy, but there are centers where they practice sentinel node biopsy. Hope the question is answered.
Thank you, Sudhir. Now I have one question. What is this true cut biopsy? I've always seen this term called true cut biopsy. What is it?
Yes, sir. True cut biopsy is like, for example, if everybody will be very familiar about FNAC. FNAC is a fine needle aspiration cytology. So you insert a small needle, fine needle, to aspirate the cells. That cells, most often that cells is enough to sell whether it is tumor or not. But certain cases, the pathologists say that we need tissue to assess it in detail. So in such cases, for example, for oral cavity cancers, it is easy to take a biopsy. But for a deep-seated neck mass, for example, a deep-seated neck mass, for a deep-seated parotid mass, FNAC, you can take an FNAC, but if the pathologist say that they need tissue, either you have to go for an open biopsy, which is a more invasive procedure. Instead of open biopsy, what we do is we have a kind of gun. It's a core, a large needle where you can insert that needle deep into the tumor and just charge the gun. The gun will capture the tissue and take it out. So it is a less invasive procedure to take deep tissues from deeper structures. That is called a true cut biopsy.
Thank you. I hope that particular point is under sentinel node means and what is the significance of it in both in terms of treatment plan and the prognosis. Any more questions? Now, so kindly somebody's audio should be muted. Sunil, can you see that? Somebody's audio. Yeah. Any more questions or any more queries?
Sir, there is a question. I could see one question. For soft tissue and midline lesions, will our treatment plan be different? So, to answer the question, the soft tissue itself does not have any impact on treatment. For example, tongue tumor, the treatment does not change. It is treated as oral cancer only. But midline structures, that is very important. Why? Because midline structures, we have to treat both sides of neck. For example, when you have a lateralized lesion, for example, a lower alveolus or buccal mucosal lesion or lesion on the lateral border of tongue confined to one side, you have to do a neck dissection on the ipsilateral side alone. But if you have a midline lesion or a lesion crossing midline, you have to do neck dissection on both sides of the neck. That is the only difference in the treatment plan in a midline lesion. But soft tissue doesn't make any difference.
Questions? Babu Modi sir, you want to comment something? You've been curiously listening to the talk like a fresher. Really inspiring for all of us. Can you unmute, sir? Can you unmute? Yeah.
Babu sir,
sir,
please unmute.
Sir, can you please unmute yourself, sir? Babu sir, can you please unmute?
Okay, can you hear me now?
Yes, sir. Yes,
yeah, now we can hear you, sir.
No, I was very patiently listening from the morning, all the three guest speakers. All of them are good. And the only thing is the topics given to them were very wide. Therefore, some of them were forced to cross time. It's a blessing that we can hear people from other countries also in the form of webinar, and this is the COVID blessing. The proceedings are going on well. All speakers definitely dealt with basics as well as advancement. I have only great respect to the speakers, and I congratulate the organizers for identifying them, and it is going on very well. Hope tomorrow also we will have the same result. Thank you.
Yeah, Sudesh, there's a question for you in the chat box. Someone has finally asked you something to do with occult metastasis and sentinel node.
Yeah. Yeah, that question. That's the thing. Sentinel node biopsy. The concept of sentinel node biopsy itself is to identify the occult metastasis, because you have an early lesion. Clinically, it is N0. Like you do an imaging, there is no nodes. So you take it as N0, but you just want to rule out occult metastasis. That is whether it is occult. So to identify the occult metastasis, we are doing sentinel node biopsy. So if the sentinel node biopsy is negative, then you take it as there is no occult metastasis and keep the neck under observation. That is the concept of sentinel node biopsy. Hope that is clear.
Yeah, that's clear. If there's no more doubts, shall we conclude the session? Dr. Sunil, you want to comment something? Any queries, any questions to Dr. Sudesh?
Yes, Dr. Sudesh, this was a wonderful presentation from you. I think all participants have benefited with this. So with no more questions, shall we wind up this session? Over to you, Megha.
Dr. Sudesh, sir, could you please start the sharing of the screen now?
Dr. Megha, I think you're facing muted. Yeah.
Thank you, Dr. Satish Manoharan, sir, for your illustrative presentation. A sincere appreciation to Professor Dr. Ethan Thomas, sir, and Professor Dr. Sunil S, sir, for moderating the session.
Thank you.
Kindly accept our token of appreciation here.
Thank you. Thank you very much.
I invite a speaker, Dr. Satish Manoharan, to accept the token of appreciation first.
Thank you. Thank you very much.
Now I invite Professor Dr. Ethan Thomas, sir, to accept the token of appreciation.
Thank you.
Now I invite Professor Dr. S, sir, to accept the token of appreciation.
Thank you.
An investment in knowledge always the best, a quoting by Benjamin Franklin. This brings us to the end of the keynote lectures for the day. I would like to thank all the clan on the other end of this virtual line for your time and much interest in these documentation. Hereby, we come to the end of keynote lectures, and we'll be continuing with the scientific presentation from 12:30 p.m. onwards as scheduled. And I would also like to invite all the delegates to join for the keynote sessions for tomorrow at 9 a.m. Thank you.
Thank you. Thank you, Dr. Mika and the organizing committee. It's quite heartening to see the number of participants. We have in excess of 100, even until the last part of the session. We started off well, and we came up to 160 participants. Now, even towards the end, we have 100 plus participants. It's a great recognition. Good work, organizing team.